Good afternoon, everyone. Welcome to the 4th Annual Food is Medicine Symposium. It's great to see so many people here today. My name is Robert Greenwald. I'm a clinical professor of law here at Harvard Law School and the faculty director of the Law School Center for Health Law and Policy Innovation. Can you hear me? Is the mic working? Hello? Okay, good. Now it is. Okay. So the Center for Health Law and Policy Innovation houses health and food law programs here at Harvard Law School. We're committed to promoting more equitable and effective healthcare and food systems and to mentoring the next generation of smart and thoughtful practitioners in the fields of health and food law. I also want to acknowledge our co-hosts for today, the incredible, extraordinary, formidable community servings. Community Servings is really our state's premier food and nutrition program, providing medically tailored meals to individuals and families living with chronic and serious health conditions. I particularly want to call out David Waters, the CEO of Community Servings. Jean Terranova as well, the Food and Health Policy Director. Both of them have been really instrumental in helping to plan this event, and you'll hear a little bit more about Community Servings later on as David Waters is presenting today. It's really, again, awesome to have so many people here today. The event is slowly but surely getting bigger and bigger each year, and mainly it's through word of mouth. I have to say, it wasn't that long ago when we started this, 4 years ago, and at the time, I just remember when I would tell people as a lawyer that we had started a food law program and we were talking about the issue of food as medicine, I'd mainly get a blank stare back at me. And then sometimes people would say, oh, does that mean like you work with Stop and Shop? So we've really come a long way, and it's just great to have so many people here who clearly care about and know about this issue. In fact, the issue of food as medicine is incredibly important to our center. As I mentioned, we have a health law and policy division on one hand that I run day to day. We have a food law and policy division on the other hand that Emily Broad-Lieb, member of the clinical faculty, also runs. And we know together that the issues of health and food are deeply intertwined, and that efforts to effectively reform both the health system or the food system often demand coordinated action. So tonight's symposium is really an embodiment of the interconnection that we see. Simply put, the law school, and we hope all of you are here tonight, knowing that the whole point of integrating food as medicine into mainstream healthcare delivery systems really will take a concerted effort by folks that are interested in food and health and public health and social justice and poverty issues, all of us really working together. We have mainstream major forces that we need to really move in the right direction, and hopefully working together we can all make that happen. So again, thank you so much for coming here today. Now, this phrase, food as medicine, can mean different things to different people. So I want to spend a few minutes talking a little bit about what the center means when we use the words food as medicine. To us, food as medicine is about the provision of healthy, nutritious food to those who have or are at risk for serious or chronic health conditions. In this context, it's a medical intervention, the prescribing of medically tailored, healthy food that ultimately meets the triple aim of healthcare reform, right? It improves individual health outcomes, it addresses serious public health concerns, and ultimately, what insurers often care about, reduces healthcare costs. So we recognize that there's a growing body of evidence that food is medicine, and it is only due to the healthcare system's short-sightedness that it isn't fully integrated already as a medical intervention into healthcare for many people living with or at risk for serious illness. The key here is that food as medicine should be paid for, not out of grants or private donations or bake sales, but instead it should be reimbursed as the medical intervention it is, funded by healthcare dollars, most often through public and private health insurance systems. So for us, our work is largely about securing appropriate resources to turn food as medicine into a reality, to scale up and replicate some of the kinds of interventions you're going to hear about today to provide healthy food as medicine. So we use this graphic to illustrate that in our view, there is a continuum of need for food as medicine. At the top of the pyramid is the low-hanging fruit, if you will, interventions based on the severity of healthcare need, with medically tailored meals being prescribed and delivered to those who are unable to shop or cook for themselves, but whose health condition can be treated or ameliorated, managed more effectively through provision of medically tailored food. Here we're often talking about the 5% of people on Medicaid, for example, who are the sickest and hardest to reach. It's often the 5% who consume 40% of all Medicaid healthcare dollars, but who could greatly benefit from a $20 a day intervention, such as 3 home-cooked, medically tailored meals delivered to their homes. And the good news is that in addition to it perhaps being obvious to all of us that the concept of providing healthy food to really sick people could help improve their health outcomes and reduce healthcare costs, it's not just us who know this, and that increasingly there's evidence base and research that really proves and establishes the importance and the benefit of food as medicine. So moving down the pyramid, there's also growing evidence of the effectiveness of food as medicine in the context of medically tailored food as opposed to meals. This is for those who perhaps can shop and cook for themselves, but who are living with or at risk for chronic and serious illness and can't readily access or afford healthy medically tailored food. For this population, the most appropriate intervention could be a box of healthy groceries with recipes perhaps included, including some basic healthcare services, food nutrition counseling, all provided at or in coordination with food banks or food pantries. The idea, again, of integrating food and healthcare as part of food as medicine. Again, the good news is, as you're going to hear tonight, the effectiveness of the use of medically tailored food to improve health outcomes is increasingly documented through scientific research. So finally, moving down the pyramid, we strongly believe in the foundational truth that all people deserve access to healthy, nutritious, and affordable food. Food as medicine includes making our safety net programs, such as SNAP, and food banks and food pantries more robust. We know that food insecurity, for example, increases the risk of chronic disease, that being food insecure is also associated with having higher health care costs. We need these programs, and we need to ensure that they have sufficient resources to be able to provide food that is healthy and nutritious. Anti-hunger efforts are essential, but they also need to have the resources that are necessary to promote stronger health outcomes, and the provision of healthy food is part of that calculus. That's what food as medicine is all about. So tonight, we're really pleased to present a program that reflects many of the important things that we all know about food as medicine, and hopefully some new research that you haven't heard about before. Our presenters are change makers in the food as medicine movement, if you will. They're pioneers who are really showing the mainstream. I see the people smiling here are doing this work. You are game changers. You're pioneers, really effectively convincing mainstream healthcare industry why it is necessary to transform business as usual and to incorporate the provision of healthy food into our healthcare system. So we're going to open this evening with looking at a group of our primary nation's healthcare safety net providers, food banks and food pantries, who are working again with healthcare providers, hospital systems, and insurers to help healthy food reach vulnerable people. Kim Pendergrass is here from Feeding America, our network of food banks and pantries, joining us for the second time at this event. You're, again, our only two-time invitee. You're doing amazing work, and it's great to have you back here with us, and it's going to tell us about the incredible new initiatives that food banks are engaging in all across the country on this issue of food as medicine. With her tonight is Connie Whitaker from the Alabama branch of the Feeding the Gulf Coast Food Bank. I think it's all integrated, right? But you're Alabama-based. And Connie's going to describe how her food bank is navigating new relationships with healthcare partners and offer her perspective of what it will take to get more medically tailored food into food banks and pantry service to help the people who need access to healthy food the most. Then, for the first time in our 4-year history of running this symposia, we're going to have 2 representatives from the healthcare payer or insurance side, along with their collaborative partners in the food and nutrition industry, describing why they are among the first insurers in the country to seize the potential benefits of medically tailored meals for some of our most vulnerable members. So we're really excited again to have the insurers and the providers that they are working with. So we have Bill George, the President and CEO of Health Partners Plan here today, who collaborates with MANA, Philadelphia-based food and nutrition service providers, and we have Sue Doherty here with us as well today. And then locally, we have Dr. Tojian Ayahi, the Chief Medical Officer of Commonwealth Care Alliance, and who's also here with David Waters from Community Servings, and they partner also in the provision of healthy food. And again, this is the transition from the bake sale model of supporting food as medicine to incorporating food as medicine into public and private health insurance systems. And then finally, we're so honored to have Dr. Timothy Harlan here, the director of the Goldring Center for Culinary Medicine at Tulane University School of Medicine, as our keynote and final speaker. And Dr. Harlan also represents a first for the Food as Medicine Symposia. He's going to talk about the need for quality nutrition education in medical school. What could possibly be more important than educating our frontline healthcare providers as to the importance of the integration of food into medicine. So again, we hope you're going to enjoy the program today. Come back next year. Continue to connect with us. Hopefully our website will be up somewhere. I should have switched to this slide so you can see the list of speakers we have. And then one small piece of housekeeping. I'm sorry to say, but the table out there with Cheez-Its and Fritos, that was for a different event, not our event. As some of you may know, our dining services folks are on strike. So despite the fact that it was originally advertised as there would be food served, we have made the decision not to cross the picket line, and so we are not bringing in outside food. We did carry in, there are some apples and other fruit and stuff at the back table. Please help yourself, but we hope you bear with us during this time of this strike. And now I have the pleasure of turning it over to one of our clinical fellows, Emma Klippinger, who's going to moderate the first panel on food banks as partners in health promotion. Thank you very much again for joining us today.
Good afternoon. My name is Emma Klippinger. I am a clinical fellow with the Center for Health, the Center for Health Law and Policy here at Harvard Law School. It is my great honor to moderate our first panel, Food Banks as Partners in Community Health Promotion Challenges and Opportunities. I'm really excited about this panel. As we heard from Robert, we have 2 speakers up here who are really at the front lines of this work. On the policy side, we look for those who are piloting innovative models and documenting their successes and their challenges. And these women and the organizations that they work with are doing just that. So I'm going to hand it over to them. I'm going to introduce Kim Prendergast and Connie Whitaker, and they're each going to speak for about 10 minutes, and then we'll do about 10 minutes of Q&A, and we'll try and stay on track because we have such a fantastic program here today. So to start with, we'll have Kim Prendergast speak. Kim is a community health and nutrition consultant with Feeding America. She is a nonprofit director, dietitian, and consultant whose work is focused on assuring that all people have access to nutritious food and medical care. Since 1999, Kim has worked with Feeding America, the nation's largest hunger relief organization, supporting the national nutrition and health strategies and expanding food bank nutrition and health education and culinary training programs. Kim also serves as the executive director of the Metro West Free Medical Program, a free clinic here in Boston that provides medical care to nearly 2,000 uninsured and underinsured patients each year. She holds a master's degree in public policy from the University of Chicago and a dual degree in dietetics, nutrition, fitness, and health from Purdue. Next, we will have Connie Whitaker. I'm going to introduce you both now, and then you can each come up and take the podium, who has joined us from Alabama. Thank you so much for coming up to rainy Boston. She is the External Relations Director for Feeding the Gulf Coast Food Bank. She has been on the staff at Feeding the Gulf Coast since 2010. Prior to joining the food bank, Connie worked for 27 years in the healthcare industry in medical sales, business development, and national accounts. She has a passion for nutrition education and brought her previous experience to Feeding America to the Gulf Coast Food Bank to help with advancing partnerships with healthcare partners to promote healthy eating and nutrition education. Connie has a BA in business from Georgia State University. So Kim, I'll bring you to the podium.
Well, thank you so much for having me tonight. It's a pleasure to be here and a great group of panelists, so I'm excited to hear what the others have to say, and a special welcome to Connie, who agreed to join us from our member food bank down in Mobile, Alabama. We've been doing a lot of great work together over the last couple of years. So let me just, there we go. All right. So I just wanted to level set, since I'm the first one up here, to talk a little bit about food insecurity. As I'm sure that you know, the United States Department of Agriculture measures food insecurity every year. The numbers just came out a couple of weeks ago in September. And we like to talk about food insecurity as the lack of access to enough food for a healthy and active life, and really focus on the impact of food insecurity on health and the ability of people who struggle with getting enough food to lead the kinds of lives and access the kinds of foods that we want for them to eat fruits and vegetables every day, eat the whole grains, eat the kinds of foods that we recommend in the dietary guidelines. The newest data from USDA is a little bit improving, a little bit positive. Down just a bit over the last couple years, but still at the high, it still hasn't come down from the highest level since before the recession. So 12.7% of U.S. households are currently food insecure, 15.8 million households and 42.2 million people. This is the map that Feeding America uses with what we call the Map the Meal Gap. The URL for that is down there, feedingamerica.org, Map the Meal Gap. This is a really nice tool for those of you interested in food insecurity data, because it demonstrates the darker the color here, the higher the rates of food insecurity. And you can see, if you compare this map to the CDC's obesity rates, if you compare this map to the diabetes rates, looks really similar. And we know that so many of those issues go hand in hand. And so I encourage you, if you haven't taken a look at this data before, Map the Meal Gap is a great place to play around and look at the issues in different communities around the country. Oh, there we go. So when we think about why should food insecurity matter to healthcare, I think it's just really important to recognize the impact that food insecurity has on health status. First and foremost, it affects the well-being of the people that we're serving in the healthcare communities. But we know there's plenty of data now that tells us that food insecurity increases risk for a variety of chronic diseases. Cardiovascular disease, diabetes, obesity, even mental health issues are tied to food insecurity. And once individuals and families are struggling with chronic disease, it's much more difficult to manage a diet-related disease on a limited income when food access is a challenge. And so we know that particularly with diabetes, there's great research these days to demonstrate, both from Feeding America and from others, demonstrating the food and medicine trade-offs that individuals are having to make, the medication adherence challenges that they have. It's tricky to manage a disease when you have to take multiple medications if you're not able to purchase your food as well. And our own research showed that self-efficacy was a much higher, much bigger problem for people who were the most food insecure. So we're seeing people in our healthcare settings who we're calling non-compliant, but they really just don't have the resources at home to be able to manage the diseases that they're living with. And there's increasing data to demonstrate that food insecurity also affects healthcare costs. There's data to show that food insecure individuals have increased rates of hospitalizations, increased readmission rates. There's some great data out of Canada that demonstrates the difference between food insecure and food secure individuals and the cost of healthcare to the system. And we recognize that this is, the more data we can track, the more we will know. So a bit about Feeding America. As Robert mentioned, we're the leading hunger relief organization, one national office in Chicago with 200 member food banks and about 60,000 food pantries and agencies around the country, serving about 46 million Americans. Through a variety of activities, food distribution, local and national programs to improve food access, lots of nutrition education around the country, a lot of work to connect people with the Supplemental Nutrition Assistance Program through SNAP outreach and actual assistance in the food pantry and distribution settings, and increasingly policy and advocacy and research. I'm delighted to not only have Connie from Feeding the Gulf Coast here, but also the folks from the Greater Boston Food Bank in the room as well. And I just want to acknowledge that the Greater Boston Food Bank has the first physician in a food bank on their staff right now, and Catherine Brodowski is with us as well today. So as I mentioned, Feeding America is doing a variety of research in the hunger and health space. And for those of you who were here 2 years ago, I spoke a little bit about the Diabetes Pilot Initiative. This was a 3-year pilot that was funded by the Bristol-Myers Squibb Foundation. So we worked with food banks in 3 different states to look at the intersection between diabetes and food insecurity. The results were published last year in Health Affairs, but what was really exciting for us to learn was that for those with uncontrolled diabetes, we were able to demonstrate a decrease in hemoglobin A1C, along with other things, including fruit and vegetable intake, improved diabetes-specific self-efficacy, reduced diabetes distress, and trade-offs between the food and medicine and diabetes supplies, choices that were people having to make. So this is really that food, the medically tailored food that Robert talked about. We're excited to be doing a follow-up randomized control trial right now in 3 new communities, looking very similar in that we're screening for food insecurity, screening for diabetes in the food pantry setting and enrolling individuals who are food insecure and who are living with diabetes into this 6-month program. We just completed enrollment. We have 571 people enrolled. Looks pretty similar to our pilot project, although we are scaling those food boxes to household size. And we've adjusted the diabetes education a little bit to be a little bit more robust because we really learned that this was the first introduction to diabetes self-management education that so many people had had. Outside of our research, we're identifying with our food banks a number of ways that we can tackle food insecurity through food bank partnerships. First and foremost, we're recognizing that lots of the clinicians that we work with, lots of healthcare providers don't understand the connection between food insecurity and health. So it requires lots of education by those who are the experts in food insecurity. So doing lots of education and helping them to screen for food insecurity at the patient visit using what's often known as the hunger vital sign. And I have a new resource that was out there to talk about food insecurity screening and making some recommendations to individuals in the clinical setting. We're also recognizing the important opportunities to provide food on site at the healthcare setting. So once we identify someone who's food insecure, opportunities to link with hospital or clinic pantries like the one here at Boston Medical Center, mobile food distributions. Again, we're seeing great work with the community health centers, linking with food banks here in Boston and around the country. Meals to take home, provided at discharge. And we're seeing places where we're doing summer food service programs and congregate meals on site, and Connie will talk a bit about that. And then other opportunities to address health at the food distribution sites. 2 quick cases I wanted to share. One that's exciting at the food bank in San Mateo and Santa Clara counties in California, where we've started a new food pharmacy on site at the clinic. So the food bank worked with an outpatient clinic to start a pharmacy where they are screening for food insecurity and providing those patients with vouchers to go to the pharmacy to pick up boxes of food, healthy food for most of those folks, some even medically tailored food for the people who are living with diabetes. And in addition to getting food, they're also getting some nutrition education and other community referrals as well. And they've seen a great uptake, 100% participation in the beginning stages. Funds for this program were through a grant that the food bank received for startup costs for the refrigeration and the shelving and things. And then it's been ongoing general operating funds through the food bank and through the clinic that they've been able to raise. We're also excited about a new partnership with the food bank in Hillside, New Jersey, and their local hospital to provide frozen meals to patients at hospital discharge. This was a program that started at the hospital in an attempt to reduce readmission rates for seniors who were being discharged from the hospital. They started a care transition program, doing a lot of work with home visits with nurses and pharmacists and dietitians. And universally, they said, this is great, but these patients don't have food in their homes. They're seniors living alone. They live with individuals who are at work during the day, and they just can't cook for themselves. And a big piece of why they're coming back to our hospitals is because they don't have food. So they contracted with the food bank community kitchen program to create meals that are frozen and given to the patients in a box. They get 5 days worth of meals, lunch and dinner, along with a couple quarts of milk, so that they are guaranteed to have meals those first 5 days until they can connect with other resources. I'm excited about another partnership that we just are kicking off this week. We were down in South Florida yesterday doing some training with physicians at a Continue Care clinic of Humana. This is a wholly owned clinic by Humana that will start doing food insecurity screening next week with all of their patients. And this is a 4-week model, and they'll have a person from the food bank on site to provide boxes of food right away. And what we're excited about with this is, with the end of this 4 weeks, we're going to have some data about the food insecure and food secure individuals, and be able to do, with the claims data from Humana, do some look back over the last year to identify the differences between food insecure and their food secure counterparts in terms of health status and health care utilization and health care costs. So we're really excited for that information and those learnings to share. And I will just leave you with the Healthy Food Bank Hub, for those of you who are interested in some great resources that we put together, including a report that we did with the Center for Health Law and Policy Innovation on creating connections for client and community health, among a number of other resources that we've put together. So thank you very much, and I look forward to some conversation at the end. And I will turn it over to Connie.
Hi, and again, Connie, I forgot to bring my name up. Gotcha. Okay. All right. So I'm with Feeding the Gulf Coast, and of course, we are a member of the Feeding America Network. And it is our mission to work through member organizations and partner agencies to provide nutritious food to meet the challenge of feeding people who are hungry as a result of personal crisis or disaster. And we also work to educate the public regarding domestic hunger and proper nutrition and related issues. So Kim mentioned the benefit of the network and the 200 food banks, and every single food county in the United States has food bank coverage. This is a map of our service area. We cover 24 counties along the central Gulf Coast. It's over 20,000 square miles. The dots that you see represent our partner agencies, which are typically church pantries, soup kitchens, and other charitable nonprofits. Of the 20 million pounds of food we distributed last year, the majority of it was distributed through partner agencies, but we do also administer special programs, the mobile pantries, the produce drops, and our summer feeding programs, the after-school snack summer feeding, which are federally funded programs, and the backpack program, which is a donor-sponsored initiative. So this is we partner with several healthcare clinics and hospital systems, and we are providing nutrition education, cooking demonstrations, recipes, and the healthy food boxes. I think you can read most of, I won't go through all of them, Mobile County Health Department. The Ronald McDonald House Charities is actually on the campus of the USA Medical Center. Kim alluded to the summer feeding program. We actually, for the first time this summer, piloted the summer feeding program at 2 hospitals, one, the Children's and Women's Hospital in Mobile, Alabama, and then also Sacred Heart Health System, which is located in Pensacola, Florida. So these are a few examples of some initiatives that we're taking, some community engagement with the food bank locally. We participate in the Mobile United Health Task Force, and this group meets monthly. It's a number of stakeholders and also the 3 hospital systems, Mobile Infirmary, USA Medical Center, and Providence Hospital are also represented there. And this year's focus is they're actually going with a specific zip code for healthy lifestyle interventions. We're also working on community gardens. Providence Hospital has one. We have a teaching garden on site at the food bank. We also have over 40 community gardens throughout the community, mostly at schools, low-income housing, senior centers, but we also have installed them at our partner agencies that you saw on the map before. We are participating in the Bayou event, the Bayou on the Move. This will be the 2nd annual, and this is a day of health screening. Includes eye exams, skincare screenings, mammograms, blood pressure checks, and so forth. And our role there that day is to provide cooking instructions. We do the demo, we provide the recipe, and then the patients are taking home the healthy meal box afterwards. And then Kim mentioned the need for education, and there's a handout that was on the table out front there. But in talking with several of our healthcare providers, they think they know the resources that are out there, but they don't know all the resources out there. So they're very interested in getting that information on where can their patients find food if they need food, or where can they find SNAP assistance. We actually have an 800 number that patients can call. They don't have to go to a DHR office. They can have the screening over the phone, and this has been very beneficial to the patients. And Kim mentioned in some settings, clinic settings, they're not asking the question, and generally they don't. In the diabetes center, they typically do ask the food insecurity screening questions, but for pride issues or just reluctant to be forthcoming with the information, they just wanted to have the information where patients can pick it up and if necessary, make the calls on their own. The majority of what we're doing with the healthcare partners, of course, is providing the healthy food boxes. They're mostly shelf-stable food boxes with the canned meats and the low-sodium items and whole grains and pastas and beans and so forth. But we also are providing a lot of fresh produce as well, and hopefully in 2017, the majority of the produce that we're providing to our healthcare providers will actually be harvesting from our own on-site garden. So this is from funding we received from Feeding America. We are going to start an initiative in January of 17 with a diabetes education series, and this will be a 6-month offering, and it's a half a day on Wednesday, once a month. And this is a free class to individuals that don't have insurance. But what's interesting, the majority of those that insured patients they do see are Blue Cross Blue Shield of Alabama. The class is a $200 class, and the insurance company will reimburse 19% or $38 of the overall cost. So the patient really is absorbing the majority of the cost on that. The classes are held in the Diabetes Center at Providence Hospital, and similar model that we're providing the cooking demonstrations, the recipes, and the food boxes. What we hear most from our healthcare facilities and hospitals is they just do not have enough resources. So we provide a dietitian to help them with those initiatives. So the success, the outcomes of the series will be that after 6 months in June, the conclusion that healthy cooking skills and confidence levels will increase for 90% of patients, that patients will be eating more fruits and vegetables and less fried items, and this is huge. Kim showed the map with the food insecurity rates a few moments ago. Our region has some of the highest obesity rates in the country. We're 1 and 2, actually, Mississippi and Alabama, and some of the highest food insecurity rates. So it is a very cultural thing, and there's a lot of work to be done. And then 50% of participants at the conclusion will have a minimum of a 5% total weight loss. And then this is just a different graphic to demonstrate the short, medium, and long-term outcomes of the program. So Feeding the Gulf Coast role with this will be we have an on-staff dietitian, and she will work with the Providence folks, and she's going to participate in the community health needs assessment and also the community health improvement planning process. And she will work with them to identify partners to educate. Not just what we're finding is not just the community, the patients, but also the physicians and healthcare providers to show the effect of food insecurity on chronic disease. And then also the consideration to how we can implement new models to have a food distribution or food bank education programs to address these needs. Some facilities are able to do that on site, but oftentimes they're not. So in those cases, we try to align the partner agency in the vicinity, or several partner agencies in the vicinity of the healthcare facility, so that their patients can be referred to get those food boxes. And then, of course, all of the work that we're doing is coming back to Feeding America so that we can track progress with these initiatives. Another program that we'll be starting at the beginning of the year was grant funded by Blue Cross and Blue Shield. This is also a partnership with Providence Hospital and the BioClinic. These classes will be held at the BioClinic, and it's a 6-week series. It's a small group, 15 patients. It will be they're each 90-minute session classes. And the first 60 minutes will be focused on their disease management, and the Providence Hospital registered or certified diabetic educator will go over that with the patients, and then our registered dietitian will provide the cooking instructions and nutrition education, and then of course we'll provide the meal box. And all both of the curriculums I just discussed used by Providence Hospital's Diabetes Center meets the standards of the American Diabetic Association and the American Association of Diabetic Educators. The success of our outcomes for this program will be measured by the patient's health outcomes, which will be measured by their hemoglobin A1Cs. Each week, staff members will measure the patient's blood sugar levels to see if they vary from week to week. Patients' hemoglobin A1Cs will be tested at the beginning and end of the series, and patients will also be given a survey at the beginning and end of the series. All of the work that we are doing, and Robert mentioned this is all grant funded. We are seeking founding national foundation, working with local foundations. They do appreciate the collaborations with the healthcare providers. They recognize it as a natural fit, and I'm being told to stop, so I'll conclude my presentation. Thank you.
Thank you so much, Kim and Connie. So we're going to open it up to all of you now. The mic is in the middle of the room. If anyone has any questions for our panelists. And Sarah may be also bringing the mic. Okay. Oh, you're making sure it's on. While you think about your questions, I have a question. And I may try and combine 2 questions into one. So Connie, you just mentioned funding at the end, and it seems like it's a pretty broad coalition of funders. You have insurers in there, you have a lot of foundations in there, and part of what we're thinking about here is how to create more sustainable funding sources. And so I'm curious on the one hand, what is most compelling for your donors? And on the flip side, because Feeding America is in the position of aggregating so much of this data, kind of where you are hoping to get more data, what kind of the outstanding questions are for you, and if there's perhaps a gap between what the donors are looking for and what you currently have.
Can you start, sure?
Well, I will say that our healthcare initiatives started with funding from Feeding America, and it was a very small project that we worked on. And over the last couple years, we've developed those programs a little more, and we are now being recognized as a credible partner with healthcare partners. And our local foundations in particular are starting to pay attention to that, and they want to see that collaboration, because what they see too often is there's similar organizations doing similar things, and they're not combining their expertises. So it is an absolute natural fit, and it's part of our strategic plan of next year to allocate more funding for this. But these are costly initiatives, but in the long run, we know that there's benefit to the patient, but overall reduced costs to the healthcare systems as well.
I'll say I think it was really interesting. We kicked off the pilot with the folks in the Feeding the Gulf Coast in an effort to learn about partnerships between a food bank and a nonprofit hospital around the community health needs assessment and community health benefit process, because we really wanted to understand, in a setting where it was a mid-sized city with just a couple of hospitals there that were doing the community health needs assessment, and understand how the food bank could work with that hospital to make some differences. And what was really exciting to see was how easily they connected and how interested in food insecurity the hospital was. They had a number of priority areas and recommendations in their community health improvement process around food access, and really discussing kind of around the issue of food insecurity, but had never thought to connect with a food bank. I think was one of the biggest aha moments that we had in the beginning of that partnership. And I think that that's happening across the country with community health needs assessment and with the community benefit process. The hospitals are trying to work in the community but don't really know how to work with partners in a robust way. So that's been speaking to the issue of the need to educate the healthcare sector on the importance of food insecurity and the importance that community benefit or community-based organizations can play. From a data perspective, and I think what the first piece of data that we collected was looking at that change in blood sugar control as a result of being part of the diabetes initiative for those patients in our pilot project that was funded by the Bristol Myers Squibb Foundation. Again, it was a grant-funded project. But that was a huge shift for Feeding America and for food banks to be able to kind of talk about having client-level data like that. And we recognized that a pilot project was important, but a randomized control trial was more important. So that was the piece that we followed up with. And I think what we're seeing right now is a lot of healthcare organizations saying this is really interesting. Once you figure out the model that works, come back to me and we're going to do that. So we're really recognizing that we need to continue to pilot and prove some of these. So right now, as I mentioned, this project with Humana, we're really excited about, because that's a piece that will give us that data of, in the United States, in this clinic, in this community, what does it cost? What are the differences between the food insecure and the food secure patients in a retrospective way? And then the next piece is really having that, okay, we know that food insecurity costs more. We know that in small ways we can make a difference on individual health outcomes. How do we screen for food insecurity? What is the model? Is it bringing food on site? Is it mobile distributions? Is it that box of food that the food bank provides to the healthcare provider that they can take home? Can we prospectively, and I know that David and his team are doing a lot of this as well, prospectively demonstrating then the full cycle. And I think once we have those, we'll have all that we need in terms of data to really run with some of these great programs. Hi, Catherine.
On that note, wonderful presentation. I just wanted to ask a question and jump in since I'm going to wear my data hat. I love talking about data. Connie, your work is fantastic. It's so impressive. I love your work with Providence Hospital, and I noticed you mentioned a couple of things. You were looking at these great outcomes, vegetable and fruit consumption, but then also health outcomes like hemoglobin A1C. And my question was, did you, as we're all exploring food banks, working with the medical centers, are you internally thinking about research, or are you approaching others for research partnerships? Are you doing IRBs with outside institutions, or how are you doing that to tackle the health outcome questions there. And then my second question, if I can, and then I'll scoot back to my chair, is about screening. What have you seen locally in your medical centers? What are the big barriers? Are they still trying to screen with paper, or are they adapting their EMRs, or what's on the ground that you're seeing? Thanks.
Okay. Actually, Providence came up with the measures and the outcomes. So they're dictating, and they've identified, and same with the BioClinic on the 6-week initiative there. So we're relying on them to set those outcomes, and which they'll share, which is of course benefit, because in working together, the more information, more data we have, the more work that we'll be able to do. The second piece of that, what did you ask me, Catherine?
Screening.
The screening. It's not happening in most cases. It just isn't existing. It's not even on the radar in most cases. And of course, in the diabetes center, they're doing that routinely, but it just isn't happening. We talked, one of the things we discussed with a potential initiative with an insurer is to, as they look at the EMR and the food insecurity questions, to start implementing that. But that was a situation where we had a champion with Cigna Health Spring, and she left Cigna Health Spring. So we are back at square one. She's going with Viva?
Yeah,
Viva. So several steps forward and another step back.
And I think that's a common occurrence, that a lot of this work falls with one person as opposed to being systemic at this point. There's been a lot of effort around instituting food insecurity screenings into the clinic and hospital settings. The American Academy of Pediatrics recommended that all pediatricians screen all patients at all of their well visits, which was a huge win. The American Diabetes Association recommends that as well. And we're seeing in some settings that it's actually being included in the EMR system. So Epic, which was one of the big ones, has included that in their newest version of the EMR, and some other, thanks to ProMedica and the Root Cause Coalition and some of their work that they've done. And we're seeing some other locations, some other EMR systems that are starting to look at that. But a big piece of what has to happen is then making sure that those providers have a resource to share. We can ask the questions about food insecurity, but if they haven't made the connections locally, if they don't have a great way to refer that patient to get food access today, to get connected with SNAP, to get connected with a local agency to make sure that they continue access, providers are not excited about asking more questions if they don't have a resource to answer. So that's a big piece that we're really trying to develop these models, make them easy for food banks, make them easy for their agencies to institute, such that we can make it simple for providers and begin to get that institutionalized.
All right, so this will be our last question, sadly.
I came in a little late, so maybe you had already tackled this, but I oversee sustainability at Partners Healthcare, and I work with our 15 facilities on a lot of what you're talking about today. But we're applying an additional filter of local, organic, sustainable food and, for example, antibiotic-free animal proteins. I was curious if this is something that has entered the conversation as not just something that you're tackling food insecurity, but also ensuring that it's sustainable produce or food, which will continue to support the patients and stuff.
Yeah, so I think we're seeing, at this point, we're really focused on trying to prove some of these outcomes, and not as much a focus on the organic piece of it. But to the extent that we're connecting individuals not just with food bank food, but with local food, some of the best outcomes I think we see around the country are when we connect individuals with SNAP, and then use the farmers markets. A lot of those EBT programs, the double up buck kinds of programs, have a lot of great success in getting people not only connected with food right away, but also linking them in with those local sources of produce, increased fruits and vegetables, and it helps to support the local economies as well. So I think that there's a lot more that can be done, and the more that we're able to sort of prove the model, then we can start to get even better about drawing from more local sources. We have across the country, there's a variety of really great ways that food banks are working with their local farmers, but I think that's a big opportunity for us as we move forward. So thanks for that question.
Next steps. All right. Well, thank you both so much for kicking this off. Thank you. I'm going to have Sarah Downer, a clinical instructor with the Center for Health Law and Policy, up, and she will introduce our next panel.
Hi, everyone. My name is Sarah Downer. I'm a clinical instructor here at the center. I'm going to ask our panelists to come on up, and we're just going to do a little switch out of the table tents so you'll know who they are. So I'm really excited to welcome our panelists today, in particular because I lead our work on food as medicine here at the center. And as Robert said earlier, the speakers who are sitting up here tonight and the work that these guys are doing together, this is going to be the spark that transforms the way that food is considered within the healthcare sphere, is used within healthcare. So you guys are going to hear tonight, and you're going to walk away totally convinced of this as well, but we believe that this is the future. We believe that the work that these guys are doing is going to change everything. So I'm honored, as always, to be joined on this stage by representatives from two amazing nonprofits. We have David Waters from Community Servings and Sue Doherty from MANA, who represent nonprofits that have for decades been providing people with healthy, delicious, medically tailored meals to people who are sick at no cost, always at no cost to the person who receives the meal. So this is amazing work. It's an inspiration to us at the center, both because their mission of serving people who are sick and don't have a lot of resources is really in line with what our mission is, but also because the level of the service that they provide is really outstanding. You'll get a sense of that, but I do want to tell you that one of the benefits of working with these guys is that we sometimes get to eat their food, and it's incredibly delicious. So we really respect their commitment not only to connecting clients with the food that they need to heal, but also to giving them food that actually tastes really good. So David and Sue have each played many, many roles within their respective organizations. They've been instrumental, both of them, in broadening the number of clients that their organizations are able to serve over the years, the diversity of the types of meals that they're able to provide. They have each been recognized multiple times for their skill in nonprofit management, as well as for the impact of their work in the communities of Boston and Philadelphia, respectively. And then they're joined tonight by representatives from from a health insurer and then an insurer and integrated care delivery system. So we're really excited to have them that specialize in serving populations who have a lot of complex healthcare needs. So from Pennsylvania, we welcome Bill George, the president and CEO of Health Partners Plans. And Health Partners Plans serves individuals eligible for Medicaid, for the Children's Health Insurance Program, or Medicare. And its Medicaid plan in particular has been rated among the 15 best in the country, #1 in preventive care in Philadelphia, according to the National Committee for Quality Assurance. And then under Bill's leadership, Health Partners Plans has really actively been seeking opportunities to innovate, to change the way care is coordinated, to change the way it's paid for by introducing disease management programs. And its partnership with MANA is yet more evidence that it's really willing to think outside the box and move quickly to adopt the kinds of smart business practices that are going to improve health outcomes for the members that they serve. And as with Sue and David, Bill has been recognized numerous times, both for his work with Health Partners Plans and for his significant community contributions. And from just across the river, we welcome Dr. Toyin Ajayi, the Chief Medical Officer of the Commonwealth Care Alliance, a nonprofit health plan and care delivery system here in Massachusetts that focuses on serving eligible individuals who are eligible for both Medicare and Medicaid. So those are folks that are either over 65 and low income or disabled and low income. And under Dr. Ajayi's leadership, Commonwealth Care Alliance has implemented a care model that really emphasizes care coordination and community medicine. She's a family physician. She maintains an active clinical practice. She sees patients admitted to Boston Medical Center. She has years of experience teaching students in both medicine and public health and has been recognized for her skills as an instructor. She and Commonwealth Care Alliance have really been a leader among Massachusetts health insurers for so many years, and their partnership with Community Servings, I think, really reflects her deep understanding of the challenges that her patients and the members of Commonwealth Care Alliance really face. So we're going to begin by hearing from David from Community Servings and Dr. Ajayi from Commonwealth Care Alliance, and then we'll move on to hear from Sue and Bill about the partnership between MANA and Health Partners Plans. And what we'll do is we'll have everyone speak, and then we'll open it up at the end for questions. So can I invite David up?
I am so excited to see you all here. I want to echo Robert Greenwald as a co-host for tonight on behalf of all of our community servings team. We're so impressed with the speakers that have come to join us really from all over the country and how exciting that is, but also how many friends and collaborators there are in the room tonight. And so we are so much stronger together. If we're going to break new ground, let's do it together. So. I thought tonight I would start out by giving you sort of a general context of what medically tailored meals are, which would lead into the research projects and the insurance projects that are coming up. So Community Servings is a food and nutrition program. We've been around for 26 years, feeding people who are critically and chronically ill, who are unable to get out of their homes and shop and cook for themselves. We feed roughly 1,100 people a day in 20 cities across Massachusetts. Our roots, like MANA's and many of our colleagues in the Food is Medicine Coalition, are in the HIV community. Quick history of HIV. The majority of people before the first drugs came along were, in the AIDS epidemic were actually dying of malnutrition. They had what was called AIDS wasting syndrome, where young men were losing 30 to 40 pounds of muscle mass in a very short period. So we figured out that if you could feed people, and in those days it was cream and butter, you could try and keep them alive longer while we were waiting for the first drugs to come through the pipeline. We like to think of it as the first example of food as medicine, and everything that we've done since then and our colleagues around the country have done since then is building upon that. So we started feeding 30 people a day in 2 neighborhoods of Boston. We now cover 20 cities across 300 square miles of Massachusetts. But we're the only program of our type in New England. So while we can brag about 20 cities, think of how many communities could benefit from this in the 6 New England states or really across the United States. Our disease population, we serve folks with 35 different illnesses. The top 4 are HIV, cancer, breast cancer being the largest of the cancer populations, kidney disease, and diabetes. If you counted diabetes as a primary and secondary diagnosis, it would be our largest population. But what I think is most important is 92% are living in poverty, but that's not how they qualified to join our service. We're not a poverty-based program. But 71% have multiple diagnoses. So as you'll see in a second, when you start talking about complex medical diets, these are patients who aren't dealing with just HIV or just cancer or just diabetes. They're coping generally with a whole mix of them, which is why Robert's point about 5% of the population taking 40 or 50% of Medicaid dollars is why that's so important. The intervention that we offer in MANA's is roughly similar, is medically tailored meals delivered once a week, lunch, dinner, and snack for 5 days, with 17 different medical diets. So renal diets, diabetic diets, low vitamin K if you're on a blood thinner called Coumadin, food allergies, et cetera. But what's extraordinary is that a program like ours can combine them in up to 3 different ways. So you could be a lactose intolerant, diabetic, managing your glucose levels, with kidney disease, managing your potassium levels. Now, unless you're a dietitian in the room, I challenge you to say, where's your potassium in your diet? If we all don't know it, how do these folks know it? How are they going to manage their health through their diet? So it's incredibly important to be able to prescribe a multiple specialization diet for folks. All of the food is made from scratch, right down to the soup stocks, so it's both appetizing, but we know exactly what's in it, and it's using local farm produce that we've harvested as surplus from local farms. And combined with that is nutrition counseling and nutrition education, such that we can make sure you're on the right diet as your doctor changes your meds or you've lost your appetite, how to help you through that period of chemo, et cetera. The challenge for us is that there's no funding for this. HIV is unique. It's the only population in America where we've said we ought to feed sick people. Over a beer, I'd be happy to tell you the whole history of that. But when programs like ours went beyond HIV, it required philanthropy. So we raise a lot of money, $4 million a year, to feed people. But programs like ours carry a waiting list of about 75 people who could be on our program's waiting list. Even though we triage the waiting list, they could be on it for 3 months. Now, if you can't feed yourself because you're too sick and you can't get out of your house, you certainly don't need food in 3 months. You may well have passed by then. So the challenge for us and the policy discussion and the research discussion is how do we meet that unmet need all across America and find a new funding source? And that's really the healthcare discussion. Community Servings is blessed to be next-door neighbors with CHLP, the Center for Health Law and Policy Innovation, and they mentored us in the early years of the ACA, because I come from the restaurant world. I certainly couldn't make it through the first 3 pages of the ACA documents. But they were wonderful partners for us, and they pointed us to dual-eligible demonstration projects, which originally didn't mean anything to me. But where we stumbled upon was wonderful partners in the Commonwealth Care Alliance through their One Care and senior care options. CCA has pioneered a model of integrating the social determinants of health, including nutrition, through its Senior Care Options program, which is capitated payment plans serving seniors 65 plus who are also eligible for Medicaid. But with One Care, as the ACA came along, it's also testing in a demonstration project to do the same thing for patients who are dually eligible, meaning they're Medicare and Medicaid, and they're a younger population, 21 to 64. Keep in mind that Community Servings' average population, other than healthcare, is about 45. So we are not a senior Meals on Wheels program, although a third of our patients are seniors. We were lucky enough to secure 2 contracts with CCA, and we've served over 300 people to date. Some of the things that we've learned, it's really an incredible journey that we're on, both with CCA and as a human service, having roots in the anti-hunger world, we've turned into a healthcare startup. And so we're really learning about the ACA and about that as we go. Understanding the structure of the plans, where we might do outreach, where we might recruit people from, who we should be talking to, who we're able to talk to. What's the diagnostic code for medically tailored meals? They can't prescribe it for everybody. We don't intend this particular intervention to be for everybody. It's for people where a medically tailored meal could have a significant impact on their health outcomes and cost savings and hospitalization rates. So working with the CCA around diagnostic codes and what that would mean, eligibility criteria, an evaluation plan, how do we make the argument for this going forward beyond a demonstration project? Learning about electronic billing. We're a program that has been charity-based. We didn't understand necessarily how to do that initially, although we've gotten good at it. And then offering nutrition assessments, counseling, and education as potential add-on services that a health insurer could buy from us. To delve into, Toyin's going to go into more of the partnership and the research, but I want to touch on a couple of research points. The one that I think if you leave nothing else tonight with is that 1 in 3 patients in America enters the hospital malnourished across the board. Their stay is going to be 3 times as long based on malnutrition, and their costs are going to be 3 times as high. Address their malnutrition with medical diets, and you will have an immediate impact potentially on healthcare cost savings. In our own studies, Community Servings first did a white paper where we were interviewing our referral partners. 96% felt we were improving their patients' health. 65% we were decreasing hospitalization, and improving medication adherence. We are now in a study with Mass General Hospital, Dr. Berkowitz, with 35 type 2 diabetes patients. We're just finishing the recruitment phase of that, and we should have data in the spring. Those are folks that are reporting both food insecurity and poorly controlled blood sugar and A1C above 8. The challenge is that the hospital knows exactly who's got an A1C greater than 8. They have no idea who's food insecure. So it involved calling thousands of patients to find out who would qualify and who was appropriate for the study. We are also just launching a partnership with CCAA on research funded by the AARP Foundation, which will look back at the billing data for the 300 patients we've fed over the last 3 years with CCA, and that'll be a 1-year study. I'm also really excited to announce tonight that we are a finalist for a Robert Wood Johnson Foundation grant to do the same thing for our entire population. So looking over the last 6 years at about 3,000 patients and mining the All Claims Payer database in partnership with the Department of Public Health to look at what the cost savings were when they were on the meals program versus a control group of 9,000. It's Evidence for Action program, and we hope to hear soon about moving forward with that 3-year research study.
I have to just echo how thrilled I am to be here. It just feels like these are my people. I never thought I would say that as a doctor in a room full of lawyers, but I feel very, very comfortable here. So thank you so much for the invitation. And thank you, David, for just the introduction that you gave to this really important work. I'm thrilled to be here to tell you about our population, the folks that we serve, and to really hopefully provide some color and some human stories that will really drive home why this is important. There's a ton of policy questions here that I hope that we have a chance to really delve into. I've tried to call some of them out, but I think there's going to be real ripe conversation afterwards. So my name is Tarina Jai. I'm the Chief Medical Officer of Commonwealth Care Alliance. We're a Massachusetts-based, my slides are kind of wonky, but it's fine. I'll talk you through them. We're a Massachusetts-based organization that serves exclusively people who are dually eligible for Medicare and Medicaid. And that makes us pretty unique as an organization. Our roots are as a provider out of a primary care practice that was tailored towards folks with very severe physical, intellectual disabilities. We were the first large primary care practice that had a capitated model for Medicaid patients who had severe physical and other disabilities, providing home-based care primarily for these folks. Over the last decade, we've grown to serve 2 populations through 2 programs. And I'm really thrilled to see my colleagues here from Mass Health, with whom we partner very, very closely on these very, very challenging but incredibly important populations. The first program is Senior Care Options. These are folks who are above the age of 65. The vast majority of them are on Medicare. They're also low income on Medicaid. They're frail. 62% of them do not speak English or speak a primary language other than English. 2/3 of these folks have not completed high school. Very, very few of them actually self-report being in good health, which is really important. And 3/4 of our population would qualify for nursing home placement. The vast majority of them stay in the community. And our goal is really focused on providing individuals with the supports that they need to live healthy and independent lives to the extent that they can. On the OneCare side, this is the duals demonstration, where Massachusetts was the first state in the country to embark on a duals demonstration that was enabled through the Affordable Care Act. This was a really bold and incredibly important effort on the part of the federal government to finally align payment sources for the populations of individuals who are by far the most costly to the healthcare system, whose needs are incredibly complex, and who, largely because our 2 major payers, Medicare and Medicaid, were not aligned, often got the very, very worst of the healthcare system. They fell through the cracks. These are folks with very high acute care utilization. Nobody owned them. Nobody really felt accountable for ensuring that they got the services that they needed in the system. CCA was really thrilled, largely just out of our mission and our values, to be the largest plan in this program. We dove right in. We now have well over 11,000 beneficiaries in the One Care program. 70% of our individuals have a behavioral health diagnosis. Almost half of them screen positive for depression. About a quarter have severe persistent mental illness, things like schizophrenia, bipolar disorder, major depressive disorder. 7% are homeless, but we know that many, many more are marginally housed at risk for homelessness. We have very, very high rates of substance use disorders, as you can imagine. And across our population, there's just incredible trauma. I can't really describe what that means unless you've seen and worked with our populations. But if you can imagine what it feels like to be born in poverty, to watch people die, to suffer, to get the worst educational system, to feel vulnerable every single moment of your lives, and to be let down by the healthcare system, those are the individuals that we're seeking to serve. And understanding their social needs is critical to delivering care in a way that is actually going to be effective. We manage, as an insurer, over $800 million a year in annual blended premium, so Medicare, Medicaid. And we've been really fortunate to have the flexibility within that premium to spend it effectively as we feel our members need. We have incredible flexibility to really invest in social supports. And that's been really, really important for us. Quick idea about our model of care. It starts in the very left for you, which is about trusting longitudinal relationships. It's about giving people, for the first time for many of them, a person who's their person. They can name them. They're committed to being out there, to walking with them. They're in the community. They're able to go see folks at home. They're a phone call away. And through those relationships, we start to build an understanding of what our members need. We do comprehensive assessments. They're home-based for all of our members who we can find. There's some of them we just can't locate yet. Often they're incarcerated or in shelters or otherwise don't want to be found. But for those that we can find, we go to them. And we meet them at home. We meet them in a shelter, on a street corner, in a Dunkin' Donuts, wherever they feel comfortable. And we start to learn about them. And what we find is that they may have seen 15 doctors in the last year, but nobody ever asked them if they felt safe at home. And nobody ever asked them if there was food in the fridge to take with those 15 medicines that say take after breakfast. Nobody asked them if they felt like they knew where they were going to sleep that night. And our assessment helps us to understand those unmet needs for care that span the medical spectrum, but go far beyond into community life. We then build around our individual beneficiaries interdisciplinary care teams, behavioral health, social work, primary care, you name it, that are able to really wrap around our members and provide the care they need in the location that they need. And that often means home-based care. And together what we're finding is that we decrease acute care utilization while improving the quality of life for our beneficiaries through these integrated models. This, I'm sure, again, I'm preaching to the choir. You have all seen this. We recognize that social determinants of health are critical, and that if we don't ask about them and start to address them in the healthcare system, we're not ever going to be effective at starting to improve the quality of life for our members. So we ask about all of these things. We ask about community and social contexts. My favorite question when I see patients in the hospital setting is, do you have a person? Can you tell me the name of one human being who you trust, who you would trust to make decisions on your behalf? And you would be shocked how many people don't have a person. That tells me so much. That tells me that we really have to begin at the very beginning in building a construct around that person. We ask about economic stability, employment. How do they make the rent every month? We ask them about food. We ask them about cultural competency of their providers. And we recognize that we have to do something to address them. And so again, through the flexibility of our blended premium, we're able to invest very heavily in things that traditional health plans would not. Air conditioners for frail elders at risk for respiratory complaints or dehydration. Way more important than their inhaler sometimes. These are folks who will end up in the hospital when it's 100 degrees and they're sitting in this stuffy apartment and they can't breathe. Well, let's put an air conditioner in. It makes common sense. It's not medicine, but it's actually way more powerful for folks like that. Transportation, not just call 911 and get an ambulance to get you to the hospital, but what about getting to those appointments? What about getting out to day programs, to socializing? What about other critical activities? And then things like moving and home organization. We have beneficiaries sometimes who've been on the waiting list for housing for years and years, and they finally get a beautiful apartment, and they don't have a soul to help them pack up and move. We can help with things like that because it's really important in accessing healthcare. And then there's food. We know that access to high quality, nutritious food is a critical issue in our population. So many of our members subsist on very tight budgets. They have physical, cognitive, social limitations. They just can't make food consistently. So home-delivered meals are one of our covered benefits. Actually, several thousand of our members receive home-delivered meals in some way. And these are identified on a case-by-case basis. Through that comprehensive assessment, through those conversations and relationships, we start to understand who's at risk for, who's at nutritional risk and who needs that support. One of the partnerships that we found very, very exciting is this partnership with community servings, because this is not just food. Now we're getting into this space of medically tailored foods, which is incredibly powerful. And I thought the best way to illustrate that, actually, today, as I was finishing up this presentation, something was missing. And so I pulled up our roster of members who get community servings meals, and I just pulled together an example for you. Caller Sarah, I've changed some of the information to make it less identifying, but this is a real person. She has morbid obesity. She actually had a pituitary tumor that was removed, so she's got dysfunction in one of the core places that regulates her hormones and steroids in her body. She's got diabetes, she's got high blood pressure, she's got chronic kidney disease from the diabetes, she's actually legally blind, and she's got a history of blood clots, so she's on a blood thinner called Coumadin that it requires very, very, very tight control of vitamin K in particular. And she lives alone, as so many of our beneficiaries do, and she wants to live alone. She wants to live an independent life. She takes 32 medicines a day. She has a diet that is unbelievably complicated, and it's actually her well-being is dependent on maintaining that strict diet. It's got to be low in potassium for her kidneys. It's got to be low in vitamin K. By the way, she's also lactose intolerant, because some people are. Has to be diabetic, and she doesn't like mushrooms. Where in the world am I going to get this meal from? Community servings is such a powerful, powerful partner in helping us meet the medical needs of our members. And so we've been really thrilled to work with them. We now have more than 300 members in the last 3 years who've received meals from community servings. And we have a real opportunity. Full disclosure, we as a health plan that is constantly innovating, we don't do a great job of research. We do a lot of things that make a lot of sense, and we do them quickly because our members need us to do them, and we don't always set up time to do research in a really robust way. Turns out it's an advantage here, because what we did was, when we built this relationship with community servings, is we thought we'd figure it out as we went along. And we did not, in any sort of structured way, prospectively really, really codify those entry criteria. We allowed people to do it through their clinical judgment. And what that means is that we have a natural research question. We can look back at folks and we can match them with folks who did not get community servings meals but who got other meals. And we can look back and match them for medical complexity and for social factors and see if there's a difference. And we're really excited to be able to demonstrate that folks who get medically tailored meals that are actually geared towards their medical conditions as well as their food insecurity have different outcomes from those who don't. So we're excited about that. The principal investigators, Dr. Berkowitz over at Mass General, we're really looking forward to seeing what this shows us. And we're really looking forward to being able to build parameters and criteria that enable us to extend this to more of our members. So I'll stop there and we can talk more later.
So I just want to echo what everybody has said. That it is such an honor to be here today. Certainly my high school graduating class would never think that I would end up finding my way to Harvard someday. So this is a pleasure. And Bill and I have such a partnership that we are going to actually do a little dance up here on stage and kind of go back and forth and piggyback on our presentation. So I'm Sue Doherty. I'm the CEO of MANA, which is located in Philadelphia. David did a tremendous job describing our history, so I'm going to kind of go through that quickly, and I don't want to ever see the stop sign. So I'm going to move through this because, similar to community servings, we were founded during the HIV/AIDS crisis. And our 7 founding members saw a need in the community where people were dying from HIV and AIDS and really wanted to provide comfort care and deal with end-of-life issues. In 2006, we expanded beyond HIV and AIDS, and so today we serve all illnesses. Last year we touched over 85 different illnesses. So we are no longer disease specific. And also because expanding beyond HIV wasn't enough, at that time we also went from a supplemental meal program to a complete meal program. So we are 3 meals a day, 7 days a week, free of charge, delivered to the clients' homes. The next slide here kind of goes on with, similar to what David said, all of our clients come through different referral sources, but they have to be seen by a dietitian. It does not matter if it's a MANA dietitian. We work with dietitians all throughout Philadelphia and southern New Jersey, but we want to make sure that they have access to a dietitian and are being evaluated. A lot of them are being evaluated through phone, but we also have dietitians out in medical offices, and clients do come to us on site. All the meals are prepared from scratch. We are a volunteer-driven organization similar to community servings. We have a staff of about 36, and we have about 3,500 active volunteers, over 125 a day in our kitchen. Today, we are serving about 1,000 clients, and we're providing about 90,000 meals a month. All the meals are delivered once a week. They're frozen. They need to be heated. At their initial delivery, they receive a set of instructions that kind of gives them out as the contact information, goes over with how they should be eating the food, what foods they should be pairing together. If they're going to have a missed delivery, who should they contact? And we always are sending nutrition information along with the meals that they're receiving. Here, we do everything by color-coded, our DOT system. So this is 11 diets that we serve, and similar to community servings, our clients are very sick. They lack resources. We are not a financial-driven organization, but the reality is over 95% of the clients we serve fall below poverty, and they're alone. Or they're the primary caretaker for a household of people that are dependent upon them. So most of them are fighting many, many illnesses, and so most of our clients are on a combination of up to 3 different diets at any time. So we are getting ready to start our 27th year as an organization. I joined MANA in 1999 as a registered dietitian, and it was a really transforming time in the organization, right? Antiretrovirals became available in 1997. Our HIV/AIDS clients were living, but not living without consequence, and that was really when we revamped the menu, the science was born, and then for many, many years we were tracking nutritional outcomes, we were tracking quality of life outcomes, and we were meeting with insurance companies and healthcare institutions, and we weren't getting anywhere. And really in 2011 was when we said, you know what, we really need to prove our worth and really our financial worth. We see ourselves as part of treatment. We see ourselves as part of healthcare, but nobody else was seeing that. And until we could prove the financial worth and the impact that we were having, the economic impact we were having on the healthcare system, we knew we weren't going to have that success. So we embarked on research. I could stand here all night long talking about the research process, but it was a 2-year process, and we were thrilled that in 2013 our research was published in the Journal of Primary Care and Community Health. I have to tell you, we were a little nervous when, we kind of were like, we're going to do research, yeah, and then we got the funding to do the research, and it was like, well, whoa, wait a second, what if the research doesn't show that we're having any impact? Then what? So it was a little scary. And I have to say, the researchers, when they did the lit review, they were really surprised to find that they could not find any other research that was done on medically tailored meals in conjunction with nutrition education and the impact that had on healthcare. There's a ton of research on nutritional supplements, on enteral feedings, on tube feedings, on education, but nothing that we could find that just good medically tailored meals in conjunction with education and the impact. And they also have really a hard time finding a comparison group that was as sick as the MANA population that we were serving, because again, what David and Robert said, we were serving the sickest of the sick. So the results came out, and here's the results. We saw an average monthly healthcare cost for MANA clients decrease 62%, which was about a $30,000 savings per month per client. Inpatient hospitalization, visits to inpatient hospitalization were reduced. When patients were discharged, they were more likely to be discharged to home. And the overall cost of an inpatient stay, they saw a reduction by 40%, where the HMO paid out approximately $12,000 less per month. So we were thrilled with these results, and before we go into where those results took us, I'm going to turn it over to Bill to talk about the history of Health Partners.
Mind driving?
Sure.
Okay. All right. And thank you for having me. Can you hear me? Yes. I am, this is not an FBI bug. I feel more comfortable dealing with this than talking into a microphone. Before I go any further, I want to acknowledge 2 people in the audience, actually a third. Kathy McCarran, who is our Vice President of Clinical Operations. She deserves all the credit. She does this day in and day out. I'm taking all the credit standing here. Sitting next to her is Michelle Davidson, our Vice President of Communications. She's praying right now that I don't drift from the reservation and deviate from her prepared marks. And My wife is shaking her head, do not acknowledge me. But anyways, she helped me get me here. Anyway, a little bit about Health Partners and a little about me first. I am not a clinician. I'm not a physician. I'm not a nurse. I'm not a dietitian. I'm a finance guy. I'm a CPA. I'm actually a recovering CPA. And that background will sneak in, and I hope it doesn't offend anybody. I've been with Health Partners Plans for 25 years, first 14 as the Chief Financial Officer, and the last 11 as the CEO, so I truly know where all the bodies are buried. A little about Health Partners Plans. We are an award-winning, not-for-profit managed care organization. We are an HMO. Depending on what legal document you look at it, we think we were formed in 1985. We serve 3 populations: Medicare, Medicaid, and CHIP. And I'll define that in a little bit later on. What makes us very unusual is that we are owned by medical school teaching hospitals. And to take that one step further, when we lose money, I pass those losses to these hospitals, and they have rather dire consequences. And when we make money, it's a cause for celebration. We currently serve 271,000 people in southeastern Pennsylvania, and depending on the product line, between 5 and 8 counties. That's the equivalent of 1 in 7 people in Philadelphia. If you've ever been to Philadelphia, went beyond the center city area, you'll notice that it's probably one of the poorest major cities in the United States. A little bit about size. We have 1,000 employees and about $2.5 billion in annual premium. Okay. I won't repeat what you all know about the triple aim, but we do an enormous amount of our work is coordinating with our providers. We give them enormous amounts of data, whether it's data downloads, whether it's spreadsheets. They can connect with us with a portal and get lots of data. We also give them gaps in care so they know what they should be looking for. In addition, health determinants is a major focus on us, is that we sponsor about 100 to 150 community events every summer, where we go out and teach our members a lot about the disease conditions. We test them, and frankly, if someone who's not a member of Health Partners wants to be tested for their A1C or the blood pressure, we said, come on and we'll give you the results. Okay. Medicaid managed care is a nationwide phenomenon. It started about 30 years ago, and now about 39 states are supporting it, and 69 million people participate in it. One of the key concepts here, and this is where my accounting comes in, is that managed care organizations really are functioning as an insurance company. Much like when you pay a premium for your automobile insurance, you're paying them a fixed dollar amount, and they're assuming the financial risk that you do or don't drive your car into a tree. In our case, the states transfer their risks for their Medicaid population to a series of insurance companies. We're paid the same amount per member per month. Very simply, if we spend more than what we pay, we lose money, and I get yelled at by our owner hospitals. If we don't spend that on money, we have a savings left, it's cause for celebration. So we're paid either a per member per month number or a fixed amount for maternity events. It is very challenging. Next, please. Okay. One of the issues that we have as any insurance company in healthcare across the United States is that our costs are going up faster than the premiums. So what we have to do is find very innovative ways to not only reduce costs, but at the same time improve the health of our members. And we look at socioeconomic factors, determinants, and we try to do lots of things. And again, we are not into publishing our results. Our objective is to improve the health outcomes and try to save some money. Next, please. A little bit about how we're regulated. Most HMOs voluntarily submit themselves to an accreditation process by an organization called the National Committee for Quality Assurance, NCQA. And there are about 150 objective measures that insurance companies can be evaluated. Objectives meaning that they can be actually mathematically computed. How many members who have been with you in a certain age cohort for 1 year period got some treatment or had something happen to them, expressed as a percentage, and you can compare yourself to another insurance company. And as it was mentioned earlier, we're one of the top 15 plans in the country, the best in Pennsylvania for preventative care. And what's most remarkable about us is that if you've ever been to Philadelphia, anyone been to Philadelphia? Few. Okay. We're on the ghetto side of Market Street. We're on top of Kmart. We're not in a beautiful building. School artwork prepared by kids in the Philadelphia public schools decorates our walls. And we beat virtually every public HMO in the country, every Blues plan, And that's what it means to get into the top 15. And we are a very scrappy, small company. Now I'm going to turn it back on to Sue. Whoops.
He'll be back, though. So, you heard about our history, you heard about Health Partners Plan's history, and so the research. So our research was published in 2013. Fast forward to 2015, we still didn't have any relationship with any healthcare institution or insurance company. We would go around, we met with dozens of companies, and every conversation went the same. It was, this is great, the research is amazing, this is a necessary product, but we don't know how to pay for it. So thanks, but no thanks. So I have to say it was in March of 2014 that Bill George and his team were invited, and I would love to say that it was through my relationship, but it had nothing to do with me. It was a senior member of management team, Ann Hoskins Brown, who had a relationship with Bill and his team through a previous job. So she reached out, she invited them into our Nourish Awards program, which we hold every March in honor of National Nutrition Month, and they came. And we presented the research, and you heard Bill say he's a numbers guy, and they questioned us a lot. They really looked at the numbers hard, but they left that night and they said, we're gonna do something. And I was optimistic, but I was also a little, I've heard that before, and we'll see. It was the next day, his team reached out to us and scheduled a meeting. And within a year's work of kind of negotiating, what I'm going to kind of go through now was really the nuts and bolts of the relationship and the contract. We worked out this really first of its kind innovative program. So we got together, we wanted to make sure that this was a program that worked for us and it worked for them. So we talked a lot, there was a lot of input from both sides on what outcomes they were looking for, and from our nutrition expertise to say, well, this would be the parameters that you'd want to put in place for the outcomes. So we talked a lot about the length of time service. Clients come on right now for an average of 6 weeks, but they can be recycled for 4 times, so they can be up to 24 weeks of the program. And they started out working, mainly looking at people with diabetes. For Amanda, a big thing was getting our kind of act together and making sure that our NPI number was up to date, getting the identification number, determining the billing codes, which was a national billing code, but then really working out with them what's going to happen with a misdelivery. How are we going to address that? Because there's a lot of time and energy that goes into making a product, delivering a product. So we worked out with them to develop a code for misdelivery. Payment was a big thing. You heard me talk a lot about that, the fact that our program is not just meals, the nutrition education goes hand in hand. That was the research that we did, so we feel very strongly about keeping that. If people are coming to us because of the outcomes our research demonstrates, we want to make sure we're giving them the product that our research was focused on. So we were not going to waver from the nutrition education and the meal program, and we ended up bundling the payments of one payment to include both. Electronic billing, which I have been warned about for many, many years through counterparts across the country. We knew that was going to be a whole new system for us, so we work with the MDON, and we pay a monthly subscription so we can bill through the electronic medical records claim. And right now, that subscription is costing us about $210 a month. We had to make sure operationally we got things in order. One of the big selling points, I believe, and one of the benefits that I think Health Partners Plans was really excited about was the driver interaction. So our drivers were actually going to the homes of the clients, and we are happy to hand deliver with that any information. So the welcoming kits that our clients get, we branded with Health Partners Plans so that Health Partners was on there. Any special information that Health Partners Plans wanted to get to their clients, we included in that, and we're happy to do that ongoing, weekly. Sometimes that information changes. And a big incentive is that we encourage them to reach out to their care coordinators, so touch points are happening with that. Another thing I want to just say, back to the operations side, was there was a lot of conversation. As the CEO of the nonprofit, I really wanted Health Partners Plans to guarantee me a minimum number of patients. And they were like, we like you, but not that much. So, this was new for them. So after kind of going back and forth and saying, we don't know what this is going to look like, what we decided from an operational standpoint is to guarantee a number of, we would only accept a maximum of 25 referrals a week. And that is really because we would not ever want to disappoint or let down or let the quality of our products suffer because we weren't operationally ready. You know, when you're adding 50 clients, that's a whole new delivery truck that needs to go out on a road if there's 50 clients in a day. So that was really critical in making sure the operation and the success of the program. Now I'm going to turn it back to Bill.
Thank you. Okay. As Sue mentioned, we've delivered an incredible 260,000 meals through, I think, the first week in October. We have about 1,200 members getting the benefits. And what's really dramatic is that we've seen a significant decrease in medical costs before and after, and a 31% reduction in A1C scores. Now, I have to tell you, this is all short-term, immediate results. And honestly, the results are a little bit stacked here in that we took our most fragile type 1 diabetics, the ones that are routinely going into the hospital, that are having the most significant challenges managing their diet, and if they consented, we put them in the program first. Next, please. We've also saw a significant reduction in hospital admissions. And this is really important. This is a CPA hat coming on right now. A Medicaid admission costs us about $12,000 to $14,000 each. That's exclusive of professional fees and other add-ons. So basically, we knew what we had to break even. And in our volume, we needed to save about 160 admissions before we would break even. And at the end of the day, to be very clear, our first objective is improving the health of our members, improving their well-being. But at the same time, we have to generate a margin. And at this point, we are saving money. And so it's a win-win for everybody. Next, please. We are expanding our focus of this product to other medical conditions, most notably heart disease. In our Medicare line of business, about 66% of our Medicare enrollees have both coverage under Medicaid and Medicare. So they're called what's called dually eligibles, and they will be getting this coverage in 2017. Next, please. Okay. HMOs love to do surveys, and the one thing I like to get from surveys is non-conforming feedback. However, in our surveys, the results were frankly wonderful. I know you can read these faster than I can, but the last bullet is particularly telling because one of the key points for the vast majority of the people is that they now understand the link between healthy eating and managing their disease. And if you know a diabetic, if you cannot manage your disease, it manages you. We also have some really incredible member testimonials that we're going to flip through because I thought you were like doing a Donald Trump on me. I was down to a 5. But anyways, everything is improving. It's all wonderful. And our program has gotten a lot of local attention. It really kind of blew us away when NBC TV came in and did a really neat show on us. And we're going to try to see if we have some time for that. But eventually it was shown in 40 metropolitan areas across the country, including Boston. So let me just flip through the testimonials. Everybody loves it. And we'll now go back to you, Sue. Okay, thanks.
So we just want to say that this is a win-win relationship. Really, I know our time is running short, so I just wanted to summarize that. Matt has been really fortunate working with Health Partners Plans. We signed 2 additional contracts with 2 other insurers who are not even as close as sophisticated as Health Partners Plans, but they'll get there hopefully. But it really is. It's just something that, to me, I think this is a no-brainer. You know, there's more research that I think needs to come out. We're excited to see the research coming out of San Francisco, Denver, and Boston. The more research that we can have to support this, I think the more that we will see this model emulated nationally. In Philadelphia, we say all the time that we see men as the pharmacy for your prescription diet. We have all been there. We have all been there when somebody has been told they have a life-threatening illness. They get all their marching orders. They get told they need to take this medication. They need to go here for their chemo, here for their dialysis, radiation. And here you have to follow this special diet. It is really complicated. And for our clients, they lack resources, they're alone, and where are they going to get that diet filled? And really we see in Philadelphia, man as that pharmacy for your prescription diet. We don't want to be the ones doing it nationally, but we want to see that model along with the coalition of agencies that we work with across the country, make sure that everybody has access to that.
One last point in terms of our future focus at this point. We couldn't be happier with our partnership with MANA. We couldn't be more happier in terms of how our members love it, but we're taking another step forward in that. As you heard from one of the other speakers, a substantial number of people on medical assistance are homeless. And we are the plan of choice for diabetics in Philadelphia and the surrounding counties. So we're currently having conversations with HUD, the regional people, as well as the city of Philadelphia. And what our goal is to test different housing structures, whether it's just giving people a place to stay from 5 in the evening until 5 in the morning and having MANA food delivered to see what do we have to do to make an impact. Do we have to just give them one night for a 3-month period in terms of giving them a place to stay and good food that's dietetically prepared, or do we have to actually put them in full temporary housing 24 hours a day? So that's our next frontier. We're trying to pick areas where we can actually have an impact on costs and then actually improve people's lives in Philadelphia. So stay tuned for our next chapter, and we're excited to work with MANA in that regard. And thanks for listening to us tonight.
Thank you.
Thank you so much to our panel. I just want to open up the question and answer period by diving right into Medicare and Medicaid. So, both of you are caring for Medicaid and Medicare patients primarily. Dual eligibles are a big part of your business. These programs are really famous, as everyone in the room knows, for being incredibly complex. As you guys know, they're incredibly complex. They may foster innovation in some ways, but they come with a lot of rules. So I want to start by asking you, are there things about those programs that are hindering you from doing all that you'd like? Are there things that are helping you? What have you found along the way to be helpful about the way that these programs are structured?
Thank you. It was not our intention to enroll 63% of our Medicare enrollees as dual eligible. It just happened. And we have significant challenges, as well as the primary care physicians who try to serve them and actually reaching out to them. We have challenges getting them in to see a provider. And even if we offer them to have a van pick them up at our cost, put them in a cab at our cost, they're afraid to leave their homes for a lot of reasons. Philadelphia, like Chicago and other cities, is subject to rampant violence. And why would you want to go outside? And it's probably safer to stay inside and roll the dice than go outside and roll 2 dice at that point. And what complicates it even further is that we try to get various organizations to then go into the homes of these people to do assessments and perform rather rudimentary medical tests, and they won't let us in for the most part. And it's a very, very frustrating situation. And maybe you have a different experience, but it's difficult, and they're very suspicious.
Yeah, so we were sort of born out of the delivery side of things, and went out intentionally to be a duals only plan, and have found that the challenges are very similar as you've described, and the solution really is about that longitudinal relationship that is mobile, so that is home-based. And so the vast majority of our workforce are clinicians and community health workers who are out there on the streets, in homes, meeting with our members and building a relationship. We also employ a lot of advanced practice clinicians, so nurse practitioners, physician assistants who are able to kind of augment primary care. So for that member who's not going to leave their house to go see the PCP, we actually have a clinician who can go into the home and prescribe if need be, and then communicate back to the PCP. So it's a very, very intensive model. We also operate primary care practices that are sort of very, very focused on disability, both being accessible but also in kind of the interdisciplinary team structure, so that we can bring people people into our own primary care if we need to. But specifically, I think we're unique and very fortunate in participating in both in the SCO program, but also in the One Care program that are designed as fully integrated demonstrations. That just gives us incredible ability to innovate. That it was sort of an explicit focus of these programs, that we have to understand how to address social determinants, and that we're actually finally able to really leverage the full kind of value and benefit of both the Medicare and the Medicaid side of the premium to do that. I think that the barrier for us, frankly, has been operationalizing all these different things. The menu of options and services that our members could need and could get is huge. How do you stratify, assess, and deploy in a way that is appropriate so that people get just what they need when they need it? It's not a one-size-fits-all model. It's an incredibly heterogeneous population. For some people, the solution to their food insecurity is to work with their caregiver and empower them to make those meals and empower them to be better educated. We can't provide meals for everybody. That's not the right solution. The right solution is to understand what a person needs and kind of meet them where they're at, and that takes a lot of time.
And I also wanted to ask you, as you were going through this, I mean, it sounds like you both had a pretty intuitive understanding that food was important to your patient populations. But was there a moment when you recognized that medically tailored meals were the thing that your patient populations needed?
I hope this isn't TMI. My father was a type 1 diabetic. He grew up in the 1920s when the treatment for diabetes was starvation. His older brother died of complications of diabetes at the age of 6. My father, future father at the time, was 3. And my grandfather took my future father, surprisingly, to Harvard here, where they were experimenting with insulin. So he was one of the first kids in the United States to get insulin. My dad became a physician like his dad, but in the 60s, when I was a teenager, I would watch my mom, who was a nurse, weighing food, determining that we were eating regular times. There was no sugar, there were no carbohydrates. We had a very, very restricted diet. Whatever could be counted easiest was what was served. What could be weighed easy and the easiest was what we served. So frankly, we had the same thing over and over again. And people joked about, you could tell time when the Georges were having dinner because it was sharply at 6 o'clock. But this is before glucometers, and I could see that the only way my father could survive was eating a very carefully controlled meal. And if there was any deviation, there were enormous impacts on his ability to exist. And for me, it was a no-brainer. There was no downside. There is literally no downside to giving healthy food to a diabetic. You're not going to make them ill. They're only going to make them feel better. You're going to give them a chance in terms of managing their disease. So this was a very easy decision for me. So a natural.
Yeah, I would echo that. I mean, I think the barrier to adoption of interventions like this is not what's the right thing to do. It's how do we pay for it? How do we structure it? How do we regulate it? It's empathy. You don't even have to I get the privilege of being a physician and meeting folks and talking to them, but you don't have to stray very far to just imagine for a second what it is like to be diabetic and sleeping on a park bench and having no place to store your insulin and having no idea when your next meal is going to come from. It doesn't take huge creativity to recognize that food is critical, just as housing is critical, just as personal safety is critical. It's how do we actually mobilize ourselves as a system? How do we get on board with the radical idea that human well-being is a right that we should serve for, and that we ought to solve for how to pay for it, and we ought to solve for how to deliver it consistently. And that's been the barrier. And I think that's, again, I feel very fortunate to get to work in a structure that I do that allows us to really start to think about exciting ways and creative ways to deliver on this, recognizing that this is a no-brainer.
Can I chime in? 10 years ago, I had a double bypass. And as I was about to be released from the hospital, a dietitian came in literally in the last 5 minutes and said, here's all the ways you're going to change what you eat. Now, what's more intimate that we do than what we eat, or what our culture is, what our family is? But all I could think of was what happens when they unplug that machine. And that's all my partner could think of. We heard nothing that dietitian told us. And that was our preparation to go out into the world and be healthy. And we have all the privileges of, being well educated, having money, having a roof, having food, speaking English, knowing how to read. You strip those away and say, yeah, go monitor your potassium levels. You're setting everyone up for failure, because even half the people in the room wouldn't know how to do that.
Thank you so much. Incredible presentation. My heart as well, personally, and also as a professional thinking about innovations in Medicaid and Medicare. I actually had a question for you about sort of thinking about the long-term nature of the work that you're doing, the study that you've done. So you mentioned kind of there's a limit of the number of meals a person receives, and you did your study of the diabetic population. Results for that intervention. I'm wondering if there are efforts to think about the long term. So, for example, when that intervention ends, would you expect to see the same level of cost savings, or how do you think about that?
Well, you bring up a great issue, and that is that there has to be a finality to this. We can't do this forever. So what we spend a lot of time doing is building other partnerships and educating our members in terms of where else can they get food, whether it's from food banks, using their SNAP cards. At the same time, the members have issues actually cooking their meals. They don't know how to cook. So we spend time teaching them how to cook. We're working on, at wellness centers that we're establishing, and actually having food drop-off zones. So at least if they go there, they can get food that's been prescribed to them by a physician. So this is going to be forever at this point. And it's going to be a challenge. So we are confident that we're going to see, for the most part, significant savings in this and improvement in their lives.
But just as a follow-up to that, so I understand that some people, maybe their health would improve, they would no longer meet whatever the eligibility criteria. But if you're finding that the health outcomes have improved dramatically, so you're also, in theory, then if you're working under per member per month, you're actually making money. Why would there be a need to remove people off of the program?
Well, right now, I will confess it that we are at the infancy stage of the program. It just started in 2015. We're not sure to what extent, at what point do we have to cut off treating diabetics and then spend more time focusing on other conditions. So we are learning as we do this day in and day out. We don't have any fixed answers.
Just a logistics question. Was it a month's supply of meals at one delivery? Is that what you were saying?
It's 1 week. One week's worth of meals.
Okay, so if you have two people who are both medically fragile in that home, do you help them to be able to get something before those meals? Because I represent a rural community, and even our Meals on Wheels recipients have limited availability in storing frozen meals. But just wondering about that.
That's a great question, and that was a lesson learned. And again, we're dealing with an impoverished population that when you open up the refrigerator, there's no food in the ice box. I'm talking like a Pittsburgher now. So what we do is we feed the entire family. So if we don't feed the entire family, the diabetic mom or dad, as a good mom or dad, gives the food to the children. And then it's a self-defeating process. So we feed everybody, but also as a corollary effect that they're all eating the same thing. How can you expect a diabetic to be able to eat a meal when the kids are sitting there eating pizza? Doesn't work. It's a family effort. So the intent is to feed the entire family. And go ahead.
And just to address the delivery component of that, we do work with many case management organizations as far as freezers, coolers, and in some cases, the households can't handle the once-a-week delivery, especially if there's multiple people in the household, and we will deliver more often.
Yeah.
So I've noticed that none of you have mentioned those striking racial disparities in food insecurity, aside from what you call it being used in ghetto, which is a pejorative term with strong racial connotations. And I'm just wondering what each of your organizations may be doing to specifically address racial disparities in food insecurity.
I'm happy to take that. So certainly that we know that in our population, in the dually eligible population, that folks of color are disproportionately represented. And we know that people of color in general have poorer health outcomes, person for person, disease for disease, when we talk about the chronic diseases that we manage. We're explicitly focused on reducing the disparity between people who are low income with complex medical, social, and behavioral health needs and everybody else in the population. And we don't have an explicit focus on racial disparities, because what we find in our population is that this is a disenfranchised population across the board, and that the interventions that work universally across our population. So, I think I hope that sort of somewhat answers your question, but this work is social justice work, and you can slice it however you choose to slice it. But implicit in the focus on addressing people with food insecurity and starting to build a consciousness around the importance of that is social justice, in my view, anyway.
I would also say that the focus on the work that we do here at the center to serve underserved populations, to work on policy change that will serve them, we do recognize that there's big racial disparities in outcomes, in rates of morbidity among the folks that we hope, we're going to do things that will get them access to better care, access to affordable and healthy food. But these are folks who are eligible for Medicare and Medicaid, and those eligibility requirements don't look at race as a factor. So when we're looking to make policy change for these populations, we're looking to make the change for all of the folks that are eligible for these populations. And because there's going to be a disproportionate number of folks who are non-Caucasian in these populations, the services are going to be delivered to them.
Can I just add one more thing? The other thing, though, I do think is important is cultural competency and actually the food composition. So, I have a lot of Hispanic, Latina patients. You can't show up with, potatoes and broccoli every night. So really recognizing that food is, it's culture, it's history, it's family. We have to be much, much, much more thoughtful about how we provide food that is actually culturally appropriate. I think that's really important, and I think there's a lot we can continue to do in that space.
In a similar way, I would say that in our kitchen, the demographics of our chefs matches the demographics of our clients. So we actually ask our chefs to bring in recipes from home. If you grew up in Haiti or Puerto Rico or El Salvador, bring us those recipes, because they're going to be more appetizing if they're culturally appropriate and reminiscent of the meal your grandmother made when you were a child.
Great. Yeah. So I'm from Cape Cod, and we're doing a fruits and vegetable prescription program where we have the healthcare system. We are an accountable care organization. We're working with local farmers market providers who are giving prescriptions for free prescriptions. We're measuring it as a randomized controlled trial. We're doing a pilot right now. And when we are trying to scale up in January, we are already thinking about the sustainability question. And my question is, this is fantastic what all these programs are doing. And there's already a setup in place, the federal SNAP programs, that has better sustainability long term. And would your programs consider partnering with SNAP to teach them to do medically tailored meals and change the way they're doing it? Because it's an already existing thing for the vulnerable population that's already there. And I think it's a policy question as well, thinking about how can this be taught, partnered with SNAP, which is already there, sustained long term.
I can just say quickly that at Mana, we do have a very small percent of patients that when they come off the meal program, so when they achieve optimal health, they want to continue to get the meals, and we will accept SNAP benefits and sell them at a reduced rate for clients that want to maintain that. It's a small percent of the population, but we do have that option.
I think there's still a piece here that we haven't come to, and this may resonate with you, which is, in practical terms, what's the return on investment for a payer, and that is a public payer or the proxy of one, in investing in what are by definition more expensive meals, because we have to really understand, I think, the people for whom this is maximally beneficial and really optimize that. And I think we haven't, certainly I don't feel like we've done that yet, which is a large part of why we're doing this research, hoping that we can identify prospectively the people who are most likely to benefit from this increased investment versus some other supplemental meal, and being able to really target those folks with the idea that we're going to see those returns down the road. And so I think there's still some work to be done there as well.
The other thing I would add is that the measurement we use is that if we can keep somebody out of the hospital for one night, we could feed them for 6 months. And not everybody needs to be fed for 6 months, but there's a strong ROI argument, and that's what the research is going to be focused on, is proving that.
I'm going to have to close it there. So I just want to say thank you again to all of our fantastic panelists. And now I have the pleasure of asking our Assistant Clinical Professor and Director of the Food Law and Policy Clinic, Emily Broad-Lieb, who will introduce our keynote speaker this evening.
All right. Okay. Well, thank you so much. I hope you have all been enjoying this incredible evening. I think we're hearing from such amazing work that's being done from a lot of different perspectives. We've heard from providers, researchers, insurers, and I'm excited to, in a moment, turn over to someone here talking about what's going on in the medical school and with doctors. So as Sarah said, my name's Emily Broad-Lieb. I direct the Food Law and Policy Clinic, which is the other program within the Center for Health Law and Policy Innovation. And because we have this great synergy of having a health program that really looks at health access and the policies around insurance and coverage. And then in my part, we look at food, and we look at kind of going back even further from all the discussions we've had. Where's this growing? Who's producing it? How is it being grown? What are the policies we have in place to get people to produce healthier food? So there's been this great synergy working together the past few years on food as medicine, on issues around diabetes policy, and a bunch of things that really I know are the things that matter to all of you, and that's why you're here. And I'm excited, as David mentioned, and Robert as well, to be working together. It's been really nice having community servings in our backyard and working together from the beginning on some of these issues with them, and then getting to partner throughout the years on this event and on a lot of other exciting things. Let's see. I think I want to go quickly because I want to not take any more time away from what's going to be really exciting and incredible. But I want to say a little bit about something that's been really resonating with me and why I'm really excited about having Dr. Harlan here as our keynote. So a really key linchpin to all of this, I think, is having doctors and people in the medical system know something about food and be able to see why this is important, to talk about it with their patients, or if they're not able to talk about it, to know that it's important enough to refer their patients to someone who is, or to a program who is, or to be able to say to the insurers, this is why you need to be covering this. Yet, just to give you a little bit of data about what medical schools do with regard to food and nutrition, on average, medical schools offer about 19.6 hours of nutrition, which is less than 1% of the total lecture hours in medical school. More than half of doctors rate their knowledge about nutrition as inadequate, and only 14% feel qualified to offer nutrition or food guidance and information to their patients. A lot of this came from, we've been working with some medical students who have brought this to my attention here within the Harvard community, and it's been exciting to kind of see what's going on elsewhere and how we can be dealing with these issues. And I think lastly, to say that patients, many of you I'm sure have experienced this, and we heard about a few stories just now. When you go visit your doctor and you have a health issue, you want them to be able to tell you what I should eat and what I shouldn't. And we have stories abound of People going to the doctor having, they're diagnosed with a heart issue or with diabetes, things like that, and not being given clear guidance on what they should or shouldn't eat or what that means or where they should go to get more information. So I think this is a really critical issue and can affect not only all the patients we've talked about in these programs who are the most ill and needy patients, but even people from early phases, even parents taking their children to visit a pediatrician and wanting to know what they can eat so they stay healthy. These are the kinds of things that doctors should be able to answer. So with that, I'm going to turn over to tell you a little bit about our speaker, Dr. Harlan, who is the Executive Director of the Goldring Center for Culinary Medicine at Tulane School of Medicine. And he's really exceptional. I want to say he's my new friend because we spent some time together today, and we're going to hopefully rope him into working on some stuff together. He runs the Goldring Center, which is the first dedicated teaching kitchen in a medical school, and he's really been a pioneer in the field of culinary medicine, not just at Tulane, but as I heard, and hopefully we'll hear more, really expanding this and sharing this with the broader medical school community and bringing the programming to others because it's so important and vital. And what's interesting is he's not only a practicing internist, but before medical school, he was a chef. So by 18, he was managing his first restaurant, and by 22, he had opened his first restaurant. So he sort of brings the food knowledge and the nutrition knowledge and what does it mean to actually work with and deal with food and marries that to the medical knowledge and medical education. And I think that's why he's so effective at what he does. And I'll say one other thing, which is that we've been trying to have him speak here for several years. I actually first learned about the work of the Goldring Center of Dr. Harlan because my brother is a Tulane alum, and I happened to be at his apartment and saw the Tulane Alumni magazine, and this was the cover story. So for several years, we've been following his work and trying to get him here because I think it's just so exciting and so revolutionary. So without further ado, I'll turn it over to our keynote.
Thanks, Emily. I'll echo the other speakers and say that, it's Harvard, right? Mr. Greenwald sent me an email a little over a year and a half ago asking me to come last year. And I had been invited to go speak in Milan. So it was kind of like Harvard, Milan. But I'm here this year, and in addition to Emily and Mr. Greenwald, I'd also like to thank you, Mr. Downer, for all of your help and support in getting me here. I'll try and compress this. This is probably about a 90-minute lecture that I'm going to try and do in about 20 minutes. I start every lecture I do with this slide. Monsieur Brillant-Savarin was an 18th century judge, a lawyer. We won't hold that against him, especially not in this room. And I think that 300 years, 400 years later, this statement, which was he was really the first foodie. He was the first guy to really write passionately about food. And I think this is just as true today. If you're eating calorie-dense, nutrient-poor food, you're going to be unhealthy. And we are really challenged in America. This is the snacks table at the 2010 Obesity Society Annual Conference. Now, we doctors go to conferences all the time. We get there, about 7:30 in the morning. We sit on our behinds, and we get up and we go out about 10:30, and they've got food there. I'm not really sure why, but they do. I think somebody thought maybe these pretzels were somehow healthy. They're really just sugar dipped in salt. And if you think this is unique, I could spend a half an hour showing you these slides. This is the 2010 Annual American Society of Hypertension. This is the afternoon snack after now forget about having a morning snack and lunch. This is after Vitrio Bodeman, one of our nephrologists, had spoken for about 90 minutes about the ravages of sodium in our diet. So for those of you who are students of irony, come spend some time with me. These are the numbers, and most of us know these numbers, or we know something that looks like these numbers. 8.3% of us with diabetes, 1 in 3 of us with hypertension, 616,000 heart attack deaths every year, 140,000 stroke deaths. And These are numbers, and you look at them and you think, oh yeah, 140. These are our friends, they're our family, they're our colleagues, they're our coworkers, and we spend a lot of money. I know there's been a lot of discussion about food insecurity, and I am becoming very rapidly a food insecurity guy. It has not been my bailiwick, but it's certainly a lot that we're now addressing at the Goldring Center. But this is the average amount that Americans spend on health care right now, out of their pocket. $4,200. I didn't spend that, which means somebody else is spending 10 grand this year. And this is the number by about 2025, $818 billion on heart disease-related illness. And these numbers are about 3 years old, $250 billion on diabetes and diabetes-related care. And everybody focuses on this number, that it's an obesity issue. And hopefully by the end of this evening, I can help you understand it's not just an obesity issue. This also has to do a lot with the quality of calories that we eat. And don't get me wrong, I would like to see my patients lose weight. It's important for them to lose weight. But there's a whole nother part of the dialogue that doesn't get discussed very much. And that's what we're trying to do at Tulane. This is a pretty typical case study that we present our patients. Most all of these come out of our own clinics at Tulane. Fairly typical 48-year-old African-American, hypertension, diabetes, hyperlipidemia. He came into the system because he had chronic active hepatitis C, as many people in this age group do. He had been put on these medications, a beta blocker, an ACE inhibitor, a diuretic, an oral hypoglycemic, a statin, the dreaded statins. He doesn't like taking medications. Our patients say this to us all the time. They say, I don't really like taking these. Works as a contractor, not a real big exerciser, eats on the run, stops at McDonald's for an Egg McMuffin for coffee, eats in the cafeteria for lunch, most of the time has a Subway turkey sub, snacks in between lunch, goes home for dinner, gets the peanut butter crackers at the vending machine. His wife came to his first visit with him. We call that internal medicine gold. When a family member comes, it's really can be really profound. And she did a lot of the cooking, a lot of times from box meals, Hamburger Helper, et cetera. These are the initial numbers. I won't spend a lot of time on them, but blood pressure a little bit on the high side. BMI puts him in the obese range, just inside the obese range. Normal kidney function. His blood sugar, hemoglobin A1C, fairly well controlled. We like to see this in our diabetics, certainly below 7, but below 6.5, he's pretty good. And his cholesterol panel, not bad, but remember, he's on medication. Now, most physicians in America, the vast majority of them, would say to this guy, lose some weight. I mean, that is the sum total of their discussion. They might say something like eat a low-carb diet. They might say something like quit drinking so much soda. But the vast majority of us would say lose some weight. And the challenge is that weight loss for us day to day in the trenches, internal medicine, family medicine, nurse practitioners, OBGYNs, the folks who are doing frontline primary care is a fool's errand. Because the fact of the matter is, when you look at the research, and there's been a lot of fantastic research on weight loss over the course of the last 15 years, comparing all different types of diet. Fad diets like Ornish, Zone Diet, South Beach, Atkins, Weight Watchers, not really a fad diet, but all of these types of diets compared head to head. This is actually the last in a very long line in the first part of the century, published in the New England Journal, 2009, 811 overweight adults randomized into 4 groups. You can see, 4 different groups. Higher carbohydrate to lower carbohydrate, lower fat to higher fat, different levels of protein. And at the end of 6 months, pretty much everybody loses weight at the same rate. Now, and they lose about 7% of their body weight. It doesn't really matter. Ornish, Zone, I mean, you can compare all of these. Their lipids improve, their blood pressures improve, their diabetes improves. Great. Most people regain that weight, and most people regain it because nobody's really teaching them about how to eat. They're teaching them a diet. They're not teaching them about food. They're teaching them about nutrition. And so, you know, it's in this context that you start thinking about what should you do and how should you do this if your patient's not going to lose a lot of weight. And don't get me wrong, I like that 7%. That 7% is great. But when you look across the landscape, what are you going to do to help patients, and how are you going to help our healthcare system make the changes because we're spending all this money? And when you look at the diet literature, the nutrition literature in the last 15 to 25, maybe coming up on 30 years, Mediterranean-style diet, the preponderance of the literature points to using Mediterranean-style diet as a model. Now, I do a whole hour-long lecture, so I'm going to compress that lecture into about 5 minutes. But when you think of Mediterranean-style diet, most of you are thinking right now olive oil, right? You're thinking fish. You're thinking fish, yeah, fish, right? You're thinking hummus or Greek salad. Red wine, of course, you're thinking red wine. You're probably thinking capers or something like that. And so that's not Mediterranean diet. That certainly are Mediterranean recipes, but it's not really Mediterranean diet per se. Mediterranean diet in the literature, in the research literature, has 9 dietary components. And they're just basically form a 9-point Mediterranean diet score. More vegetables, more legumes, we love legumes, more fruits and nuts, more whole grains, corn is a whole grain, better quality oils and fats, more fish, but less fish than you think, less fish than you think, less meat and leaner meat, less dairy, and generally speaking, more fermented or processed dairy and alcohol in moderation. And so when you take that as a palette and you look at that 9-point Mediterranean diet score, if you, in this room today, go home and do a little bit of research on Mediterranean diet and you improve your Mediterranean diet score by 2 points, just by 2 points, you reduce your all-cause mortality by 25%. 25%, irrespective of weight loss. Okay? So irrespective of losing that weight, improving the quality of calories that you consume can have a really profound effect. There's a very large trial that just got published about 2 months ago that showed that folks in the highest score, a 7, 8, or 9, have about a 37% reduction in their risk of coronary-related death. Now, the best I can get out of statins, out of the dreaded statins, is maybe 27%. Maybe 27%. So we've got something here that actually can have a more profound and a more powerful impact in what we've got to do every day anyway, which is eat. Okay? But the interesting thing is for those patients, and make no mistake, I am a dyed-in-the-wool, statin-writing, Western, allopathic physician, okay? I have no problems writing for simvastatin. But when you take simvastatin and you put it together with this, the results are synergistic. 1 + 1 = about 2.6. And we get more bang for Mr. George's buck, which is what I care about right now, and we all need to be caring about. So this 2-point improvement, you know, how do you translate that? What does that really mean? Well, when you look at some of the interventional trials that have been done, the Lyon Heart Study, for example, very large trial of first-time heart attack patients, half of them given instruction in Mediterranean-style diet, and the other told to follow a prudent diet. That was what, you know, that's the study. They're, you know, go home, follow, it's in Lyon, France, follow the prudent diet. It'll be okay. But, you know, it's just, you know, it's a prudent diet. But the fact of the matter is that, as you heard, if you come into the hospital in America today, even with all of this knowledge, you get squat. I mean, you get nothing. You get no intervention despite how powerful this can be. And a larger trial out of about 211 new onset diabetics, Mediterranean-style diet, and half randomized into a Mediterranean diet group. The other group got instruction, did get instruction, in American Heart Association low-fat diet. which is unfortunately what we're still teaching most of the people when we do teach them in America. And the folks in the Mediterranean diet group, at the end of 4 years, only 46% of those folks needed medication for their diabetes. But 70% of the folks in the American Heart Association low-fat diet needed medication. Now, there should have been maybe a third arm in that study which says nothing, because that's what most of our diabetics actually get, despite the fact that they might, in very narrow cases, if they have Medicare, if their insurance says it's okay and will pay for it, or if they can get to the dietitian, or they're motivated to get to the dietitian. So these are challenging, and what we feel we need to be doing is educating our medical professionals, and that's across the spectrum. And we need to teach them how to have those short interventions, like with Mr. H, where we do a very short, we're not trying to make our physicians or nurse practitioners into dietitians, PAs into dietitians. We're trying to elevate this discussion about food in the examination room with the patient. And how can you move your patient's Mediterranean diet score by 2 points in a very short period of time? And in Mr. H's case, that's actually, pretty easy. There's some things that you can tell him. He's eating at Subway. Get fresh, right? Subway, it's a terrible place to eat. I can tell you, Subway is probably never going to sponsor the Goldring Center for Culinary Medicine. If I tell this patient to stop eating a turkey sub on wheat bread, which is not really whole grain bread, it's wheat bread. If I tell him to stop eating that turkey sub and start taking a peanut butter and jelly sandwich on whole wheat bread for lunch every day, I've just improved his Mediterranean diet score by 2 points. I will defy any physician in America to take 30 seconds, 60 seconds, 2 minutes to do a simple dietary history and have that profound an impact, irrespective of weight loss. And the same thing with his snacks. With his snacks, pretty easy to get this guy. He's a salty, savory snacker. He's pulling the knob for the toasted cheese, for the little peanut butter crackers. Now, he wants something salty, so give the guy something salty. Tell him to go eat salted peanuts. We love legumes. Go tell him to eat cashews, salted nuts, whatever he likes. And that's what we did with this guy over a 6-year period. And notice his BMI is almost exactly the same here. This is the only medication that he's on at the end of that 6-year period. And he had actually been off of an oral hypoglycemic. Metformin is an oral hypoglycemic that helps with insulin function in the body. And we now know that even in this population, if you normalize their blood sugars, you should have them on an oral hypoglycemic to slow any further progression that they may have to type 1 diabetes. Look at this hemoglobin A1C, though. This is fantastic. This is a normal hemoglobin A1C, and lipids looking very good. So you can make, and we do day in and day out at Tulane, very significant impacts with very small, as our public health colleagues say, short, simple messages repeated over and over and over. But we have to teach our medical students to do that, and our physicians and our healthcare providers. And in that context, about 7 years ago, almost exactly 7 years ago, my dean at the time, a fellow by the name of Ben Sachs, who actually used to be here at Harvard, he was the chairman of OBGYN, a really brilliant guy. Was our dean for about 5 years. He came to a group of us, and he said, I want to build a teaching kitchen to teach medical students how to cook. And this, I will say, y'all heard some of my background. I wrote my first book on nutrition, a food manual for patients with cardiovascular disease when I was in medical school. I've written about 7 books. I have a fairly popular website. I've done some television. I've been doing this for the lay public for 20 or 25 years now. I thought this was a really stupid idea. First of all, I'm a clinician by trade and was not a medical educator by trade. And so I couldn't really figure out what what are you going to do with that? I mean, you're going to spend, I've been in the restaurant business. I know what it costs to take and run a kitchen. It's not cheap. You're going to have personnel to staff it. You got to have the food. You got to have the training. And the utility bill alone will set you back, $40 grand a year. So how are you going to take that and translate it into something meaningful? But Ben was really persistent, and he kept getting this group of us back together. I was part of that group. We had some chefs. A lot of medical students have been involved in this from day one. Our chairman of medicine, who is now our dean, Lee Ham, our chief of endocrinology, chief of cardiology, and Ben just, he kept hammering us. We're going to do this, and we're going to figure out how to make this happen. And about that time, for those of you who have been to New Orleans, this is Canal Street here, which means the French Quarter is right about there, okay? So this is Canal Street. And if you go out Canal Street to North Broad, and you turn right and you go up about 3 blocks, this is a community clinic that we were building at the time at the corner of Orleans and North Broad. Now, this is a pretty cool space because this is, again, for those of you who are students of irony, the original Ruth's Chris Steakhouse. So after the storm, this neighborhood, which is called Mid-City, took on about 7 feet of water, so right there, okay? And was under 7 feet of water for about 3 weeks, and then took ages and ages and ages to dry out. And the Fertel family, Ruth Fertel, actually had worked at Tulane as a lab tech before she opened Ruth's Chris Steakhouse, built this chain. Family sold the chain. The chain owned the restaurant, but the family owned the property. And they decided, and the chain decided not to reopen the original restaurant. They gave it to Tulane. We turned it into a community center and a clinic, actually modeled on the same sort of community center clinics that Harvard does here. Again, Ben came from Boston. And so we thought we'd put this out in the community. We'd put this kitchen out in the community. And that's where I became really pretty interested. I'm like, oh, okay. So we put it out in the community. We teach the community how to cook. And that was my core competency. And so we began this discussion. And about that time, and the philanthropy began to happen when we started talking about in the community as opposed to just, teaching medical students and having it on the medical school campus. How could you leverage that? And about that time, if you come back 2 blocks towards, this isn't the best picture in the world, but if you come back 2 blocks towards Canal Street, right about here. Okay, so this is where Ruth's Chris is. The Fertel Clinic is right here. There's a 60,000 square foot grocery store built in the 1960s. Beautiful concrete box, terrazzo floors, parking on the roof, very 60s sort of building. That also 7 feet of water, vacant, and now because there's no grocery store. And there's a community coalition along that corridor called Broad Community Connections. They wanted to repurpose this as a food hub to revitalize the neighborhood, not just from an economic standpoint, but also from a health standpoint. And Ben Sachs said, go over there and talk to these people. And I'm like, I'm not going to talk to those people. That's crazy talk. Because I'm going to have to rent, and I don't want to do that. And we've got this thing. We're doing it for Fertel. And he's like, but he's the dean. And academic medicine is like medieval England. The king basically gets what the king wants. And so I reluctantly went over and talked to these people. And it really is, these guys had me at hello. The folks, and so this is what it looks like right now. And on this side, there's 10,000 square feet. Liberty's Kitchen is a coffee shop with a production kitchen that teaches at-risk youth culinary skills. It's a 6-month program. They come out with their Serve Safe certificate, and they can work in any restaurant in Louisiana. And they teach them life skills. They teach them how to balance a checkbook and how to interview for a job, et cetera, et cetera. And there was not a grocery store anchor. There were 3 people contending for the grocery store anchor, which was going to be 25,000 square feet. And we sort of help bring Whole Foods to the table. The chairman of the board is a Tulane business professor. And they were actually opening and have opened 5 of these urban footprint Whole Foods across the country that you may or may not be aware of. One in Newark, one here, one they're getting ready to open on the south side of Chicago. And they're the first major grocery store chain to be inside the city limits of Detroit within the last 25 years. And you think Whole Foods, I know what you're thinking, I know what you're thinking. But in truth of fact, they have worked really hard to bring all of their prices down, balance the mix, and they're making their money off of those urban folks in New Orleans, the young professionals, on the stuff that I would rather them not be eating because it's off of their food bars, which are not very healthy. But the rest of it, a lot of bulk bins. They've worked trying to keep that cost, and their analysis, and we've done some checking because we buy groceries from them, is about 1% to 2% more than a Winn-Dixie or a Kroger. So they really are trying to be market competitive with these stores. And so we took 4,500 square feet of this space to build our kitchen. We have 5 key missions for Goldring Center that have evolved over the course of the last 7 years. At the core are our medical students, and we've developed a medical student courseware set, very robust. We have the core of which is an 8-module elective. It's targeted at first and second year med students, state-of-the-art, inverted classroom, all the lectures, didactics, readings, everything's done online. The students come to our kitchen. There's a case-based learning component. There's a hands-on teaching component. And there's a seminar-style learning component at the end with both clinical and basic science faculty and culinarians leading the discussion from the case-based learning piece. This was actually developed by our medical students. So our medical students have driven almost all of our content and continue to drive our content to this day. In addition to that, we now have developed about 15 condition and disease-specific modules. I think as you heard today, and I was really super happy to hear it because I practice medicine every day, and you think of diet and nutrition as cardiometabolic risk or a heart-healthy diet. But the fact of the matter is that our patients face Coumadin use, as was mentioned. They have celiac disease. They have HIV nutrition needs and geriatric diets. So we have these condition and disease-specific modules set up on the same workflow as our elective. And we've got about 15 of those now, and we'll develop a set, everything from bariatric diet to pregnancy in diet. We have 2 pregnancy modules now. We have a pediatric diet module, a sports medicine diet module, food and neurocognition, and we'll develop a very complete courseware set over the course of the next 18 months. We also now have our residency programs are using this as well. We have a 7-module series for family medicine residents, an 8-module series for pediatric residents, an 8-module series for psychiatry residents, and we will launch with our OBGYNs next week. The nice thing about this is that people came to us about 3.5 years ago and said, can we use your programming? And so over the course of the last 3.5 years, give or take a little bit, we have begun licensing our courseware for a very modest fee. We now have Goldring Center programming in 25 partner schools across the country as listed there. And everybody's doing this a little different. Some people are doing pop-up kitchens like we did for the first 2.5 years. We worked out of an ad hoc kitchen for the first 2.5 years before we moved into our space. Some people are partnering with food banks. In Orlando, they're going to do the UCF is partnering with the food bank, and they're actually going to deploy this as 3rd and 4th year programming as an elective. And they're going to teach the elective in the morning, and then the medical students are going to teach the community in the afternoon. Excuse me. We also now have about a half a dozen residency programs and just signed our first 2 nursing schools. And those are a very cool model for us because they are in community colleges, one in Northwest Arkansas, and one along the Gulf Coast in Gulfport, Mississippi, Mississippi Gulf Coast Community College. And we love that model because, again, it puts a culinary school together with an academic medical center and in rural America, because that's where these colleges are. This is our second major mission, is our community. We have developed a very robust community curriculum that I'll tell you about in a minute. And the cool part for us, and I will tell you, you start down a path with a project, and you, I think, never really know sometimes where it's going to lead you. And our medical students came crawling out of the woodwork. And so what's happened is we teach our medical students, and they teach the community. They become the force multiplier in this equation. And so when you start talking about these projects in Philadelphia, along the Gulf Coast, medical students, nursing students, they are craving this knowledge base because they see what we have not seen in medicine. They see this link, and they see the need to have that education. And as was said earlier, they're not getting it in their curriculum. We now run 6 to 7 community cooking classes every single week in our kitchen. These community classes, like our medical student classes, are free. We do not charge the community. It's probably, as many of us, I think, experience, not the best business model in the world, but it's the business model we have chosen for ourselves right now. We have a pretty robust series of curriculum. I mentioned the medical student series, 6-lesson, 6-module community adult beginner, a 6-module intermediate series. We've translated our adult beginner series into Spanish. We have a 6-module series for kids and these are kids between the ages of about 4 and 8. A 6-module series for families where mom and dad come with their kids from ages 8 to early teen. 3-lesson series for expectant mothers, and a 4-lesson series for geriatric patients, for our senior patients. These are all hands, like our medical school programming. This is all hands-on cooking. We teach people to read a recipe, parse a recipe, build a weekly menu, build a shopping list, go to the grocery store or the food bank, come home, make food, store it so you've got leftovers and you don't have to cook every day. Think about breakfast, think about lunch, think about snacks. What are you doing for those? What are you doing for beverages, et cetera? And so, the cool part about that for us is that our med students get an experience and that they wouldn't otherwise get. And we also host our dietetic interns. So you come to one of our community cooking classes, and there was a question earlier about disparities and racial disparities, and this is New Orleans. People you come to one of our cooking classes, and there'll be a little old African-American lady from New Orleans East, shoulder to shoulder with the head of HR of a manufacturing company, with a grocery store clerk, and a UPS driver, and a secretary, and a medical student, and a dietetic intern, and an undergraduate student. These, and really, really, people who would never, ever cook and eat together. And that's not only community building, but that's super powerful for our medical students, for our dietetic students. It's really fantastic. We have an amazing relationship with Johnson & Wales and now 2 other culinary schools. This was part of the foundation of what we wanted to do. We wanted to open a dialogue between healthcare and culinarians. My colleague Carl Guggenmoss with me today. Carl is the Dean Emeritus of Johnson & Wales University College of Culinary Arts, and I cold called him which I don't do, about 6 years ago, and I'm like, hey, I got this idea. And I really expected him to hang up on me. And he didn't. Carl is he didn't. It's amazing. Carl is a certified master chef and was the Dean of Deans. He ran all 4 Johnson & Wales campuses. And we now host their culinary nutrition interns. We host 4 of them 4 times a year, so we have 16 of their interns every year in our program. And then we send 12 of our medical students every year to Johnson & Wales for a 28-day rotation. So we have their culinary nutrition interns. This is a program that mints chefs who can then do a dietetic internship and sit for the RD exam. So they're chef RDs. That's who runs our program. Carl was kind enough to let us steal one of his faculty members, a woman by the name of Leah Saris, who runs our program now. Our second chef RD, we hired our second FTE about a year ago, who was one of our very first interns. Came to Tulane, did her dietetic internship at Tulane, did about a year in a WIC program, and now leads a clinical dietetics program and teaching our medical students. We do CME. You may have seen on that slide, we have 22 continuing medical education modules now. We teach practicing physicians. Our CME is certified. In my day job, the Assistant Dean for Clinical Services title means that I'm medical director for our faculty practice plan. And so I do a lot of population health management, chronic disease management. I'm thinking, exactly like Mr. George, I'm thinking about the money that we're spending every day and how can we do shared savings programs, et cetera. And so we see this as a team. And as such, all of our CME is certified for physicians, nurse practitioners, PAs, registered dietitians, certified diabetic educators, and pharmacists. And we charge providers, and we charge them a lot. That's our business model. One of our business models. We charge $200 per physician per module. They get about 4.5 hours of CME credit. We do this now actually in New Orleans about 6 or 7 times a year, 6 or 7 weekends a year. We were in Las Vegas last weekend at a conference. We'll be in Orlando. And our partner schools are now, we're licensing this courseware to them on a very small revenue share base where they take the lion's share of that revenue. But the agreement is they have to use it to stand up culinary medicine programming at their medical school. So it can't just get sucked up into the dean's office. It has to go directly to teaching medical students, teaching the community, or teaching residents. And we've had our first 2 schools do that. We'll have our third come online actually again in Orlando. We'll be there as part of the American Society of Nutrition in December, and we see this growing as well, and then we do research. So I'm an evidence-based guy. I think I said that earlier. Dyed-in-the-wool, statin-writing, allopathic, Western physician. And so outcomes are important to us. We don't have a lot of money. I mean, we run this place on a bit of a shoestring. Like everybody else, we cobble together funding from a lot of different sources. We had our initial start with philanthropy, which basically built our kitchen and gave us a little bit of operational income. We make a little bit of money off of our licensing, not a lot. Most of it comes from our CME. We also have a celebrity chef dinner series that we do as a fundraiser that raises a lot of money for us. We use our space as an event facility. So all of the research that I'm getting ready to show you is sweat equity on the part of our medical students. Now, that's cool not just because we're not paying for this research, because I'd rather be paying for it because I love our medical students, but it's a lot of work. It's a little bit like herding cats, you know. But it's also cool because this provides an opportunity for scholarship that is really hard for medical students to get. We have 192 medical students in each of our classes, and getting those scholarship opportunities is really tough. So this is what it looks like. We started a survey. It's a 55-question survey about 2 years before we actually started our programming. These are our 25 core competencies. That's 25 of the questions. 5 of the questions are attitudinal, and the other 25 questions are personal health habits. It's basically a food frequency questionnaire. So the green means we moved the needle, and it was statistically significant. The yellow means we moved the needle, and it was not statistically significant. And the red means we didn't move the needle at all, or we went backwards. And so you can imagine we got to the end of year one. We're making this up as we go along. And we were pretty disappointed in this. We had actually already revised our courseware twice by the end of this first year based on that feedback from our medical students. We went back to the drawing board at the end of year one, and we rewrote our curriculum and plugged the gaps. Our decision was, if the medical student is not getting this, it's our fault. And that's a very different attitude than most medical schools in the United States. If the medical school doesn't learn something, if the medical student doesn't learn something, it's their fault, it's their problem, it's their responsibility to learn the data and do well on step one. This is year three. And so we have moved the needle hard and fast on these competencies. This is year four. Now, we've we haven't really backslid much. These three are just not statistically significant. And we think that that's because we now include the N. The N in year one here was about 120 survey respondents. The N grows every year. This N is about 2,300 and includes all of our partner schools because that's a requirement of their license. And so we think that some of this lack of statistical significance is due to that. So they're about 4 times as likely to be able to understand and explain Mediterranean diet to their patients. That's the competencies. These are all odds ratios here. So 3 times as likely, or almost 3 times as likely to understand DASH diet, really important, very widely available to them. Omega-3 and omega-6 fatty acids, modest weight loss for diabetics. So we're pretty proud of these numbers, but we don't sit on this. We come together every year and have for the last 3 years with our partner school. Even though Tulane owns this curriculum, we view this as moderated open source. And so every school uses this curriculum as is, but if you've got to change, bring it. Bring it. Convince everybody else. Convince the other 25 schools. And this year, after this year 4 data, we made 215 changes to our medical school curriculum and deployed it before the beginning of this academic year. And we will continue to do this. Our next meeting will be, as it has been, the first week of June after the academic year ends. These are CME outcomes. No, I'm not going to spend a lot of time on these, but notice they're better. So DASH diet, even better. Low impact, very low fat diet, mostly statistically significant. And we think that some of this is better, the odds ratios are better in a smaller sample size because physicians come in kind of understanding a little bit how they might use it. We're really proud of the fact that they're about 4 times as likely to provide nutrition counseling to their patients after taking our programming. These are our community outcomes, and this is after 18 months of studying, so kind of disappointing. We see this, though, the way we saw our first-year medical student. We're going back to the drawing board. We're rebuilding our community programming as we speak. I will say, though, that we're pretty proud of this, at least one of these, although all of these are good. They're about 50% more likely to cook 5, 6, or 7 days a week after taking our program than they were before. This is our conference at Health Meets Food. I will stop there and do 2 things. One, culinarymedicine.org is where you find us. And then the second is my call to action for you. My call to action is, if you know of a physician who wants to part with a couple $100 and come to New Orleans and do our CME, we'd love to have them. They can go to culinarymedicine.org today and register. So go when you see your doctor next week, maybe. Just say to him or her, hey, I got this place that I want you to go. My real call to action is, if you know of a an academic medical center in this country, anywhere, who you think is interested in this, we will get on a plane and fly there. I will talk to them. Our mission, we got this down pat. We're running it in New Orleans. It's a machine. I will get on a plane and go see them, and we will help them stand up programming just like this. That is our mission now at the Goldring Center for Culinary Medicine. My email address is tharlan@tulane.edu. T is in Timothy, HARLAN, @TULANE.edu. Again, thanks for inviting me. And I don't have any time for questions, I don't think.
Why don't we take a few? People, if you need to leave, we understand we went a little late, but I think a lot of people probably want to.
I'm happy to, and I'll stay around as long as y'all want me to. I like it when I answer everything.